A very good morning to everyone. A warm welcome to the Ceylon College of Physicians Specialty Update in Endocrinology, organized by the Ceylon College of Physicians in collaboration with Sri Lanka College of Endocrinologists. Today's event focuses on the most critical and evolving topics in the field of endocrinology, bringing together expert speakers and engaging case discussions. To commence, I would like to invite Vidya Jyoti, Professor Prasad Katlanda, President of Ceylon College of Physicians, to deliver the welcome address.
Good morning, ladies and gentlemen, colleagues from the endocrine fraternity, and members of the Ceylon College of Physicians, ladies and gentlemen. It's a great pleasure to welcome all of you for this specialty update in endocrinology, where I also have a bias being an endocrinologist. And so to make it very interesting and useful for the common physicians, including the internal medicine physicians, as well as other specialties like cardiology, nephrology, and all other finer specialties, we have selected some useful and common areas in endocrinology, where group of experts, I can say they are world-level experts in endocrinology, will discuss in a very different way, where we are going to present common scenarios where the patients will present to us rather than purely going by theory, and then discussed by a main resource person, and also helped in the discussion by another expert panelist. So we hope that this is going to be a very interesting and a useful specialty update. And I would like to thank all of you who have come here and who will also come during the course of the day, as well as the people who have joined by remote technology. Thank you very much.
Thank you, sir. I would now like to invite Dr. Dimuthu Muthukuda, consultant endocrinologist at Sri Javadhanapura General Hospital, to provide the introductory remarks for this session.
Good morning to all of you. It's my privilege as being here, representing the College of Endocrinologists at this special event, the specialty update of the Ceylon College of Physicians in the field of endocrinology. As Dr. Katulanda, Professor Prasad Katulanda mentioned, it's a very important event because we have lined up a very interesting and challenging series of cases which will be discussed in the form of a panel discussion. And I think this is very important because these sort of events are very useful for all of us to understand the beauty and the fascination and also the challenging nature of the field of endocrinology. So as I said, our president, Dr. Mudita Veerakkodi, was unable to be here in person today to represent the college. So I consider this as a privilege being here, and I genuinely hope that this event will be a great success and will be a very productive event to all of you. Thank you very much.
Thank you, madam. Next, we are privileged to have Dr. Mudita Veerakkodi, President of the Sri Lanka College of Endocrinologists, who will join us online to address the audience.
Good morning. Welcome to the Specialty Update in Endocrinology, organized in collaboration with the Ceylon College of Physicians. As the President of the Sri Lanka College of Endocrinologists, it is my great pleasure to take part in this event, and I'm indeed thankful to Professor Prasad Katulanda, President CCP, for inviting us. As the Sri Lanka College of Endocrinologists, we have always collaborated with the CCP in organizing events to enhance the knowledge and skills in endocrinology amongst its members. I believe that this is the first specialty update for 2025 organized by the CCP. To make this event more interesting and interactive for you, we have arranged a number of cases in the key areas of endocrinology. Although I'm not able to attend physically today to some other commitments, my wishes are always with you. I hope that we would continue to collaborate with the CCP in organizing this kind of events in the future, and I also hope that you would find this session both interesting and useful. Thank you.
Thank you, Madam. For the first half of the discussion, let me invite our moderator, Dr. Tharanga Samarasekara, consultant endocrinologist at District General Hospital, Negombo.
Good morning, everyone. For the first session, we have two very fascinating topics, fat and fractures, right? So I hope I'm not offending anyone by saying fat. So the first one is a case discussion conducted by Dr. Atri Vaninayaka, who is a senior registrar in endocrinology. I invite her to come to the podium. And we have the key resource person, Dr. Manilka Sumanthilaka. He needs no introduction. I can tell you a secret. Dr. Manilka is a very ardent food lover, but I know him for many decades now. And despite his love of the food, somehow he's keeping his BMI in check. Right? So I hope he will let us know his secret today to how to keep his BMI in a steady state. And I would like to also invite my colleague, Dr. Chatri Javardhan, to the stage.
Good morning. We warmly welcome you all to the CCP specialty update on endocrinology. So today's first topic would be on obesity beyond energy balance. So the outline of today's discussion, we will be discussing about 3 different cases based on different facets on obesity. And at the end of the presentation, each of the cases will be discussed by the resource expert panel, and the questions will be answered at the end. So I believe at the end of the first case discussion, you'll be able to redefine the word obesity, which we are trying to engage on etiology assessment, evaluation of a patient, detection of complications, and the available methods of management, including surgical options currently at our practice. So our first case, this is Mrs. J, a 53-year-old female housewife with a background history of diabetes, hypertension, and dyslipidemia for a considerable period of time. And she has undergone menopause at the age of 40 years with no history of recent rapid gain of weight. She has family history of diabetes, hypertension, dyslipidemia, and obesity. On examination, you can see the BMI is 48.9, which is high, and waist circumference, we have measured 113 centimeters. Her blood pressure is elevated, and she does not have any evidence of hormone excess syndromes or syndromic features. She has acanthosis nigricans with a stop bang of 7 out of 8. So this is the investigation that we have done on this patient. So initially, when we are evaluating a patient with obesity, first we have to diagnose the obesity. So for that, we use anthropometric measures, including the BMI and the waist circumference. As we go in the lecture, you will understand BMI is not enough to diagnose obesity. So it's a crude marker at present. So we have to have a weight circumference as well. And also we have to have a whole body DEXA scan for fat estimation. So in this patient, it was 51.7. And following the diagnosis of obesity, we went on to exclude the secondary pathologies. We have done the hormone panels, including the ODST, which was normal, and whether this patient has complications of obesity. So for that, you can see there are alterations in the liver functions, but the FIB4 score maintaining exclusive of liver fibrosis. She has a diabetic component, but within considerable control. And her lipid profiles are deranged, and her ultrasound scan showing grade 2 fatty liver. Cardiac assessment shows a high TRPG of 50 with diastolic dysfunction. Her sleep studies are normal, but spirometry is showing a restrictive defect. And she has a secondary polycythemia of HB of 16.6 with a high hematocrit. So this is a real patient in our clinic who's awaiting to undergo bariatric surgery. So with regard to that, we have done the pre-op investigations, biochemical optimization, and also we have done the psychological assessment and the nutritional assessment as well. So this is the whole body DEXA scan that I talked about. So in the first, I think you all can appreciate the fat percentages are equally high in all the areas of the body. So we call this as absent differential fat distribution. So this is a simple case of obesity. So this is Mrs. J that we usually encounter in most of the time in our practice. So she has metabolic syndrome. So these are the diagnostic criteria for metabolic syndrome. I know you all know most of the included criteria, but I want to stress this waist circumference. We have to take the population and country-specific definition for patients given waist circumference. So the presence of visceral obesity, presence of hypertension, and insulin resistance. She already has diabetes, but we can use in a patient who is in pre-diabetic range or non-diabetic, we can use HOMA-IR, quick index, which is currently available at our setup to detect the insulin resistance and the high triglycerides and low HDL. So our case 2 would be, it's Mr. C, a 25-year-old male patient with a background history of headache and increased with features of increased intracranial pressure at the age of 7 years. Diagnosed to have craniopharyngioma with obstructive hydrocephalus, and then she had undergone surgery with recurrent residual tumors. Ultimately, the radiotherapy was also given, and after that, with the post-operatively patient sustaining panhypopituitarism and currently on hormone replacement with thyroxine, hydrocortisone, and IM testosterone monthly injections. Now, this patient comes with a history of weight gain for 1 year duration in the post-operative period, and he complains of hunger even after meals, which is an important point to note. And says to be having adequate physical activity, and in the history, he did not have any evidence of hydrocortisone over replacement or hypogonadism. Since this was diagnosed at 7 years, I'd like to stress he had attained his normal height and weight milestones. So we have a BMI of 46.875 and the waist circumference of 105. In this patient, and there was no evidence of hydrocortisone over replacement. Blood pressure is normal, and she did not have any evidence of insulin resistance or any syndromic features. So in the MRI brain that was most recently done, you can see there is a pituitary mass with mass effect. And again, like the previous patient, we have done the anthropometric measurements suggestive of obesity. But in this patient, we have not done the whole body MRI with body fat quantification. We have excluded the secondary causes to look for hydrocortisone overdose. Clinically, he did not have, but biochemically as well, if you see the hydrocortisone day curve is within normal range. Testosterone is in normal range to exclude hypogonadic component, and thyroid function and the IGF-1 levels, which was done initially, was normal. We have looked for the complications. Again, this patient has elevated liver functions with grade 3 fatty liver and fasting blood sugars and HbA1c within the pre-diabetic range, and altered lipid profile. And the sleep study says moderate risk for say, and they have considered for CPAP treatment. And the spirometry again showing restrictive lung disease with the 2D echo showing TRPG of 45, mild pulmonary hypertension with diastolic dysfunction. So if you see initially the patient is normal, later on with these interventions done, patient has gained weight. So this is called hypothalamic obesity. Remember the name, we will be discussing about the pathophysiology and underlying mechanisms which we encounter with regard to hypothalamic obesity. And our third case would be Miss A, a 23-year-old female with who had a birth weight of 1.5 kilos. And when we went around her records, we saw there was hypotonia documented at birth with delay in developmental milestones. She has had congenital developmental dysplasia of bilateral hips, and the mother was claiming to have a rapid weight gain and hyperphagic behavior observed after the first year of life. So also contributing, there are poor school performance and behavioral issues, including obsessions and temper tantrums. So this patient was referred to us because of her delayed glucose control. So the fasting blood sugars and the PPBS was high. And we diagnosed type 2 diabetes in this patient and started on treatment. Additionally, she did not again have any hormone excess symptoms, attend menarche at 11 years of age, but she complains of irregular cycles of oligomenorrhea. So this is a CHDR. If you see, you can see there is rapid gain of weight. Initially, the weight is lower down, and there's rapid gain of weight after age of 1 year. And in the other documentation also, you can see there's delay in her developmental milestones. So this is this patient. In 1 year, she looks normal child, but with 3 years, 5 years, and at present, you can see she is gaining weight. So, and the waist circumference of this patient was 100 centimeters, and the BMI was 31.92. She had these almond-shaped eyes, acanthosis nigricans, and small mouth with thin upper lip with the downturned corners of the mouth. So the anthropometric measures, as I said, we have done. Whole body MRI, which was not done. We have excluded secondary causes with hormone assessment. We did not perform any genetic analysis, so you have the clue that this should be a syndromic patient. And the complications-wise, she has a diabetes, but see the fasting blood sugar is within normal range, but HbA1c is high. So probably postprandial hyperglycemias are there in this patient with deranged lipid profiles and liver functions. And in the 2D echo, there was a diastolic dysfunction, and sleep studies and spirometry was normal. So this is a case of Prader-Willi syndrome. I have included the major criteria and minor criteria so you all to get an idea on this syndrome. So over to you, sir.
Okay, so I hope you got the spectrum of, it's just for an introduction. Earlier one, BMI of 45 or 48, but simple obesity. We could not find any endocrine abnormality or genetic abnormality. The second one, there is obvious cause, childhood surgery, pituitary surgery, probable disruption of his, hypothalamo-pituitary axis, and that has caused obesity with replacements. There could be so many reasons there. And the third one is a genetic defect from birth, how things have evolved. So this is just an example and how the spectrum. But all of them are having obesity. So now we have to look at, is this a disease or is it a consequence of other events, right? So the hypothalamic, yes, you can say, and the genetics, you can say to a certain extent. But what about the first patient, right? So now when people sort of question what is obesity, is that a risk factor for other problems? Yes, certainly that is there. Or is it a harbinger of other diseases or things to come in future? So that also can be there. And is it a disease by itself? So if I may ask the audience, how many of you will agree or disagree? Is it a disease or is just a risk factor or association? Those who say that is a disease, can you raise your hands? Okay, so half, I think less than half. So let's see what the definitions say and what the authorities also have coined this. So that is what the latest definitions given by the Endocrine Society and the ADA and the WHO as well. And of course, in South Asia also, we have given a similar definition. Am I audible? Okay. So it's a condition characterized by excess adiposity without abnormal distribution or function of adipose tissue with causes that are multifactorial, bit complex. What it's trying to say is it's not just simple fat. And it's a sort of a varied, so some people, they have global distribution of fat, as what we saw in the first case, right? Then some have central obesity, like in Cushing syndrome, and without Cushing syndrome also some have central obesity and less, so the apple and the pear, apple shape and the pear shaped bodies, right? And earlier it used to be just a simple an abnormal excessive fat accumulation at, which presents a risk to health. That was a very simple explanation, but I think the top one is more explanatory. With the evolving knowledge, we know that the fatty tissue is not just fat. It's becoming one of the very active endocrine organs. There is leptin, adiponectin, resistin. So there are lots of new hormones that you will have to brush up a bit and read up. When I think most of you would have been out of medical school, finish your physiology when these hormones were discovered, probably. I don't know. There are very young people here. And so it's a connection between the fatty tissue, then the hormonal central control of metabolism, incretin hormones, the gut, and it's an interplay of all these factors, and of course the behavioral, supratentorial effect is also there, comfort eating, behavioral factors, all contributing to this whole spectrum of this. I would say we can easily call it a disease state with so much difference in the hormonal balance. Inflammation is also associated, which we can see in later slides. So I would, would not hesitate to call it a disease state, right? So if you look at the world, numbers are staggering. So these are different data. Billions of people are either overweight or obese, as you can see from this map. And then predicted rates, now we have reached 2025. So this is an older map that we are showing. Go to the next one. Okay, so these are some predictions, so we can quickly go through the numbers. As you know, all these predictions go wrong. Most of the time when it comes to NCDs, what we project is, overtaken much earlier than what we expect, like in diabetes, right? So the numbers are staggering. So can we see some Sri Lanka? So this is the world, obesity map. Darker the shade, higher the prevalence. And then Southeast Asia is, if you can see the world, Northern Europe, Australasia, and the Americas, they are higher, obesity rates are higher, right? In Asia, our part of the world, actually, comparatively, it's less. But I will tell you there's a paradox here, which they haven't identified. But if you take the diabetes map or the metabolic syndrome map in the world, our areas are red. Now it's going up, rate is high. So this theory of thin fat Indian or the South Asian phenotype, where we have more central fat compared to the BMI is not a good gauge for us. So at a lower BMI, we are getting more of these metabolic complications, even with little bit of fat, which is more active, the central fat, which is more active. So we have the thin fat, we can say the South Asian phenotype is there, which is not shown in this map. So that's the explanation we have, okay. So, and over the years, obesity, overweight, all the parameters, men and women, how from 60s to 2017, 18, how the percentage numbers are rising, we are showing here, so we can quickly go through that. Similar, the area South Asia, it's relatively less, but when you look at the consequences, diabetes and metabolic syndrome, we are on par with the other countries. So we are getting that at a lower BMI. So that's the problem if you just purely go with BMI, right? Okay, so similar slide, males and females, it's the same pattern that shows. So this is interesting. This is a more 2022 study where we have checked the prevalence of obesity in men, women, and boys and girls. That is very important there. So the prevalence rates are given there, and with the age, you can see as the age goes on, the obesity, overweight, all that is increasing. And similarly, the prevalence of diabetes and the NCDs are also increasing in people. So the percentage they are shown by done by Dr. Renuka Jayatis says about 7% there, and overweight and obesity will be more than 30%, right? So this is by the international standards she has gone, the BMI of 25. Actually, for us, BMI above 23 will be overweight when it comes to the metabolic risk. So that's why you see a lower percentage there. 7.5% of the young boys are obese, even by international standards. So that's a worry. Young diabetes and all that. So that's interesting, recent data from Sri Lanka. Yeah. And then Chaturi will go through the pregnant population and comment on obesity and pregnancy a little bit.
Thank you, sir. As we all know, pregnancy is a landmark. It's a turning point in every girl's life. However, regarding to the weight journey, again, pregnancy is a very important turning point. So again, we have real world data. This is the study done in Sri Lanka. So when you take the ladies in the first trimester, this red bar depicts the mothers who has normal BMI, and the green one is overweight, and the purple bar depicts the mothers who are obese. So once the pregnancy advances from first trimester to second trimester to third trimester, you can appreciate the women who are obese and overweight, the percentage increases rapidly. That means our women get more weight during second and third trimester. It is the pure adipose tissue. Therefore, so if we read the recommendations for total weight gain during pregnancy, we have to think about the pre-pregnancy BMI as well. So if a lady who is pregnant, if a pre-pregnancy BMI is less than 18.5, she can gain around 12 to 18 kilograms during pregnancy. However, a mother's or a pregnant lady's BMI is more than 30 in pre-pregnancy, the recommended weight gain should be 5 to 9 kilograms. That means when a lady who is pregnant is obese pre-pregnancy, she can gain a little bit of weight, because this gaining weight can increase the incidence of gestational diabetes mellitus, so it is associated with preeclampsia, and this gaining weight is an independent risk factor of macrosomia and instrumental deliveries and increased perinatal morbidity and mortality. So this is about the pregnancy. What about the postpartum period? I think most of our women will be gaining more weight during postpartum period due to the cultural benefits and the cultural beliefs. They usually eat for two, and sometimes they eat to increase the milk production. So as healthcare professionals, we have to educate these young women, because the postpartum weight loss is mandatory to become healthy, and then even they can, as we discussed, the gestational diabetes mellitus is an eye-opener of type 2 diabetes. So you can prevent type 2 diabetes in patients with GDM by losing weight, because losing weight can do miracles. So I think as healthcare professionals, we have to think about that.
Okay, now coming back to, so that's a very important thing Dr. Chaturi mentioned. So diabetes and all these metabolic problems, they are becoming womb-to-tomb diseases. The seeds are for the child, actually, the fetus, the epigenetic changes, all that will be laid if the mother is obese, develops GDM, the child will be at an increased risk of getting diabetes at an early age. That is well documented with the epigenetic changes. So when it comes to the little bit more complex, etiology, pathophysiology, and the illness, so we will discuss in more detail. Can we go to the next slide? Classification by etiology. So there are many classifications, but this is a simple one. It can be primary, like or simple, what we explained before. Secondary, you all can see the hormone, different syndromes that it's associated with. And of course, genetic, you all saw the last case, and similar cases can have genetic. Mind you, now there are 3-4 well-documented single gene defects associated with obesity. The most recognized one being the melanocortin 4 gene defect, receptor defect associated with obesity, and leptin deficiency or leptin resistance gene associated obesity, just a single gene defect, and they become really obese. So this new information is there, and few other syndromes have been identified associated with genetics, and Prader-Willi is also a similar one. And I think the apple and the pear shape I mentioned before as well, which gives a different perspective. So when it comes to obesity, so the topic given by your president and our colleague is like beyond energy balance. It's definitely beyond energy balance. It's not just, we used to think it's like a scale where how much you eat and how much you burn, or the body burns out, and the imbalance, the excess food or the calories will be deposited as fat. That happens. That also is there, but it's more than that. So there is obesity is becoming a genetic or neurogenic. That part is not mentioned here. Nutritional, metabolic, environmental, and psychological and psychosocial. So all those factors have a huge interplay in the pathophysiology of obesity. So these are very interesting new area. Energy intake is, of course, there always. Binge eating, food addiction, satiety, all that. So even that energy balance is all controlled mainly by the central control of metabolism, your hypothalamus. And if I may answer Taranga also now, so when you are more relaxed and holiday, yes, you can, some of the orexo, so we have got the orexogenic and anorexogenic hormones which have been well recognized. So I can't go through all of them, but if I may give few examples, ghrelin will be a orexogenic, increases appetite hormone. Leptin will be a anorexogenic. Neuropeptide Y, cholecystokinin. So it's very interesting. So many new hormones have been discovered, which is coming from the leptin, and adiponectin is coming from the fatty tissue. Then the incretins. All of you are very familiar, GLP-1, GIP-1. Those are all anorexogenic hormones, and which increases the basal metabolic rate, energy balance, increases the affects the energy balance in a positive way, and some of the other hormones will affect that in a negative way. That box, we don't have to remember all this, but just get the concept. So it's the arcuate nucleus and the periventricular nucleus of the hypothalamus, I would say, is the gateway to all these pathways, where melanocortin 4 receptor is in the middle. So there are stimulation chemicals activating that receptor, and some are blocking. So POMC, pro-opiomelanoid, you don't have to know the names. Then agoutin-like protein. So these are neurotransmitters. The neurogenic element I'm talking about the one which stimulates the melanocortin 4 receptor will reduce the weight. Those who inhibit will increase the weight. Just remember like that. And all those factors coming from the gut, fatty tissue, ultimately goes through that final common pathway. They are in the arcuate nucleus in the hypothalamus. And there is lots of effects and endocannabinoids. So those are also feel-good hormones, the cannabinoids. So that also has an effect on people. So different drug abuse, psychiatric conditions where we have comfort eating. Sometimes the eating will, increase those cannabinoids and you feel like eating. So when there's an imbalance or problem in those chemical entities, different reasons, you will get obesity beyond your energy balance or whatever you do, basically, right? Okay, so then this also has simplified that for you to just concentrate on leptin, ghrelin, and GLP-1, GIP-1. I think for now that would be enough. Gut is an evolving area. We haven't understood 100%, but you have seen certain microbes in the gut has been identified, which is promoting obesity, and the others will make people actually in rat studies, in the gut, twin rat studies, they have shown that they have done fecal transplants with those so-called good bacteria into one twin and the bad bacteria into other twin, and they have shown that one becomes obese. So that is real, but we haven't mastered the amount of the correct combination of the gut microbiota, which needs to tackle these problems. See, other cancers, diabetes, all that also partly paid by these pro-inflammatory cytokines, TNF alpha, interleukin 1, 6, all that will increase your cardiovascular risk, inflammation. There's inflammation associated with obesity. So it's a very dynamic, fatty tissue, gut, and the hypothalamus, which is causing all this. So you can see the complexity of the situation. If we may again simplify this now, because we showed so many things, just remember this, the fatty tissue, your balance between leptin and adiponectin from the fatty tissue will affect in a negative or a positive manner in your hypothalamus, which will either you gain weight or you lose weight, or your set point of satiety, basal metabolic rate is set by the interplay of all these hormones through the melanocortin 4 receptor, which I showed there, the final common pathway. And from the gut, if we can go back to the previous one, the other one, no, the next one, sorry. Next, simple one.
Yes.
Next. That one, yeah. So GLP-1, you all know the GLP-1 receptor agonists are having a good effect. So that is through that. So it would act centrally. And it increases, promotes gastric emptying. It slows down. So they have found out if your gastric emptying is faster and satiety is low, you tend to gain weight. So if these hormones and drugs will slow down your gastric emptying and the satiety comes faster, and then the energy balance is set in a more positive manner where you lose weight. So that's one way of acting. Then the ghrelin. When the stomach stretches, the ghrelin, it's a orexogenic. Ghrelin promotes your appetite and weight, right? So it's mainly coming from the greater curvature. When that is stretched, the ghrelin output goes down, and the vagal efferents also. And that inhibits the brain and say, enough, you had enough. So this is a whole saying your grandmothers would have said, "Me lamyage bada harila." Have you heard of that? Like a big stomach, bottomless pit. Sometimes people say, some people have to really eat a lot. That's the thing. Until they get their ghrelin inhibited and the vagal efferent, they have to eat, otherwise they can't sleep also. So those are the things that, so with bariatric surgery, what happens? We make the stomach smaller and the ghrelin is inhibited earlier, the stretch reflex, right? So the simple method, it's not just making the stomach smaller in bariatric surgery that you lose weight, it's the correction of all these hormonal imbalances, the orexogenic and the anorexogenic balance that is, change in a positive manner, then that's how you lose weight quickly. Okay, so, and there's a lot of physiology, but I thought we must introduce you all to this. This is the twin cycle theory by Roy Taylor. You all must read up in Pathophysiology of Diabetes. There is a hepatic cycle, you take positive energy balance. There is increased liver fat. So fatty liver is real. It's a harbinger of lots of other diseases, not only cirrhosis and non-alcoholic fatty liver disease, but type 2 diabetes. That's where the seeds are laid, and you get insulin resistance, increased fat. When the liver is saturated, it spills over to the VLDL, and the fat goes, free fatty acids goes to the pancreas. And intrapancreatic fat is recognized as a main reason in type 2 diabetes, where impaired insulin secretion and stunning of the beta cells, we say. If you lose that fat, that is the direct study, very low calorie diet, people have lost 15 to 20% of their body weight, obese people, diabetes has been reversed in 50% of those people. So, and MRI spectrometry has shown liver fat and the pancreatic fat has disappeared and the diabetes has reversed. So this is the twin cycle theory when it comes to fat, intrahepatic and intrapancreatic. So your limbs may be very thin, the Asians, but we are more prone to have central fat. And if you have fat in your liver and the pancreas, you had it. So like the Europeans, you don't have to be really big. You're at a lower BMI, we are at the thin fat South Asian phenotype that we are talking about. So please read up on this twin cycle theory. It's very interesting, right? Oh, okay.
As mentioned earlier, body mass index, the BMI, is it a real measure of adiposity? Actually, historically, the obesity is classified, depends on the BMI. We all know how to calculate BMI. It is the weight in kilograms divided by square of height in square meters. So this is the WHO guidelines on obesity, depends on the BMI. So the overweight, the normal BMI is 18.5 to 25, and we consider the individual is overweight once their BMI is more than 25. So the overweight cutoff goes to 30, so 25 to 30 overweight, and then the obesity class 1, 30 to 35, obesity class 2, 35 to 40, and obesity class 3, more than 40. So this is WHO classification of BMI obesity. So this is the popular YY paradox picture. If you can appreciate, both of these individuals have same BMI. The BMI is 22.3 in both of them. However, when you consider the body fat, it is only 9% in the right-hand side individual, and it comes to 21% in left side individual. So the same BMI, they have very different body fat percentage. That reflects that the BMI, is this the correct measure of adiposity? We are worried about adiposity and we do not worry about the muscle mass, because the pathogenesis, the pathologic feature is the increased adiposity. So is this BMI-based definition of obesity correct? We have people who have higher BMI and they have higher muscle mass. And we have individuals with excess fat mass, but they do not have any illnesses. And we have individuals who have illnesses pertaining to obesity. Therefore, is this BMI is a correct measurement of obesity? So as I mentioned earlier, Asian populations have more body percentage to a certain weight when compared with white populations. And there is a concept that is sarcopenic obesity, that is metabolically obese people with normal weight. So we cannot go only by BMI. So duality of cut points for defining overweight and obesity is available, and sometimes it is. There are cutoffs for each and every country as well. So it is not universal. However, we can get the cutoffs for Asian countries as a whole. So this is the Asian cutoffs, the Asia Pacific perspective. We tend to reduce our BMI cutoffs. So it is same as for Sri Lanka. I think the next slide. So they have country-specific overweight and obesity cutoff. We do have our cutoffs as well. So the next slide. This is our cutoff. Actually, it's the Endocrine College of Sri Lanka defined this a few years back. So we consider normal as from BMI 18.5 to 23 and overweight 23 to 25, and obese we tend to keep BMI of 25. So BMI is not enough as a measurement of adiposity. Therefore, in each and every individual, we have to measure the waist circumference, and sometimes we have to calculate the waist to hip ratio, and sometimes waist to height ratio as well. Ideally, we need a DEXA scan or a bioelectrical impedance measurement of fat percentage. However, in each and every patient with obesity, it is not practical to do DEXA as well. So there are some practical implications. Therefore, all adults should be screened annually using initially BMI, but you have to measure the waist circumference, and if possible, you have to go with a DEXA scan to calculate the body fat percentage as well. So we take waist circumference in Sri Lanka. Also, we take more than 90 centimeters for male and more than 80 centimeters for female. And we take BMI cutoff of more than 23. And according to the WHO, the fat percentage for South Asians by 25% for men and 35% for women, the obesity cutoffs. So this is the most recent article which was published in January 2025 in Lancet. They are going to redefine obesity to advance the care for better lives. So like diabetes and pre-diabetes, they have defined clinical obesity and preclinical obesity. Clinical obesity is considered as a disease, and preclinical obesity is a risk factor for disease, and it's like pre-diabetes. If you don't intervene, it goes to diabetes. Like the preclinical obesity, if you don't intervene, the patient become obese. So the preclinical obesity, there is a risk to health, but the clinical obesity is illness. So how do you define clinical obesity? So the obesity involves each and every system of our body. So if we consider the upper airways, presence of obstructive sleep apnea, if we consider the cardiovascular system, the presence of hypertension, so there is a lot of things, and musculoskeletal system, the chronic severe knee or hip pain. So actually, yes, this could be due to obesity, but these all symptoms could be due to other causes as well. So the bilateral knee joint pain in a patient who is obese may be due to inflammatory arthritis like rheumatoid arthritis. So you have to exclude the sinister pathologies before attributing it to obesity. So if the patient is having one of these symptoms, it goes to clinical obesity, and the clinical obesity is a disease. So we have to manage the clinical obesity with giving targets and with drugs and sometimes with surgeries.
I think we are running short of time, so we have to rush through the next few slides. So I think this is a busy slide just to show the management options available for obesity, different. So if your BMI is more than 40, just lifestyle intervention won't do anything. You have to, so we have to go for better ones, like obviously something like bariatric surgery. So there is a maximum that you can do with diet and exercise also. But you should not discard that. There is a maximum that you can do. Because your basal metabolic rate, 70% is set by the other factors. Only 30% is the one that can be changed by an individual by behavioral changes. So that's the fact. So hypothalamic obesity cannot be just tackled by diet and exercise. You need the specific drugs like setmelanotide, which is a blocker, agonist of the MC4R receptor I was talking about, or bariatric surgery would be the best for those people where, all these factors will be, the neural and neurohormonal factors will be corrected. So that's what we are trying to say. So this is a spectrum of things. Never forget the diet and exercise, behavioral therapy, psychotherapy, if there's comfort eating, stress, all that can, affect those neurohormonal pathways. And of course, so many, shall we go to the drugs? So very low calorie diet has, as I said, can reverse diabetes, plus it helps with the obesity as well, and a good exercise regime. But these are the drugs that are available, that were available historically as well. Orlistat is available in Sri Lanka, maximum 5 to 7% with a good diet and exercise, right? Then Quismia was there, but now it's not, it's taken out because there were side effects with phentermine. Then Saxenda, the GLP-1 receptor agonist, the higher doses of GLP-1 receptor agonists are good weight loss medications. The most latest being Monjaro or tirzepatide, GLP-1 and GIP receptor agonists, where up to 20%, in an obese person, up to 20% of weight loss has been achieved in about 6 to 8 months of treatment. So that's the best that we have gone medically. Beyond that, so we have reached just the lower margin of bariatric surgery. So beyond that, it's definitely bariatric surgery. That setmelanotide, that's a new drug for that hypothalamic obesity, which stimulates the melanocortin 4 receptor. That is a new drug which we don't have. Okay, so how this GLP-1 receptor agonists are working, multiple effects. The brain decreases the gut motility, and then liver hepatic steatosis, decreased insulin resistance. So multiple effects. So these are very good drugs, but still very expensive. Once a week injections can be given. Semaglutide is the leading one, and tirzepatide is the even more expensive but better one. Twin creatine, right? Okay, so bariatric surgery, I would say, for the super obese, the first patient, BMI more than 80, and even probably we have to think about whether the patient can psychologically manage, but anybody above BMI of 35 can be considered for bariatric surgery, or BMI above 30 with other cardiovascular risk factors, diabetes with other comorbidities, even above 30 can be considered for all these bariatric procedures, which, as you can see, many procedures are there. This is not the time to go through all that, but those who are not willing for surgery, there are endoluminal, which we haven't put here, right? Endoluminal procedures as well. Gastric balloons, which can be put for a year and removed. What does it do? Stretching, right? So the simple mechanism where you deactivate the ghrelin and the vagal efferents, right? So we are trying to work with that physiology. So endoluminal procedures are there. Then gastric sleeves are there. Gastric, endogastric, like a condom you can put in the duodenum for a year and then you take it out. It prevents the absorption. Temporary measures, but this is bariatric will be more, permanent, and these are the treatment goals that we have for individual diseases. For diabetes, 5 to 7, 10% overall, if you can reduce the weight of an obese person by at least 10%, you can get the good results to start with. May not be ideal, but some people will need even up to 20, 30, 40% weight reduction, depending on the person. Right. Okay, so coming to I think we have talked about all this, the high molecular markers, inflammatory markers. I think we ran short of time. Can you go to the next slide, please? So high HSCRP can be a marker, so not well validated, because the obesity itself, I told you the physiology, will increase these inflammatory markers and increase the cardiovascular risk of people. So all this it's a future evolving. We have to get the normal ranges and think about monitoring patients on treatment for obesity with these markers when they are validated. They are not validated at the moment, postulated markers that you can use. Okay, so hypothalamic obesity, I think we have talked enough. I think this is just a summary. I gave you the physiology, and we have the 2 cases post-surgery and the genetic defect. And these are the common causes that you have to identify in your patients who are not responding to general measures. Think about hypothalamic obesity as well, and how they are affecting. I think we have discussed all this repetition. Can we go quickly? And the treatment modalities you give where it's affected. So all these drugs, newer drugs are also in the pipeline. At the moment, topiramate, setmelanotide, GLP-1 receptor agonists would be the main ones which will interfere with the different pathways that we were talking about and get a good result to reduce the weight medically. And of course, surgical therapy, we have talked about bariatric surgery, and even the Prader-Willi syndrome, we can try if the person is psychologically prepared for that, right? So we have to get a good psychological assessment. And the management, again, we are repeating the drugs that we have and in the world, but not in Sri Lanka. We have GLP-1 agonist and orlistat, which is we are using, but the other drugs are not available in Sri Lanka. Little bit about growth hormone for that second patient with craniopharyngioma. Sometimes if the tumor is not growing, we can give them growth hormone replacement, which will reduce the obesity, right? And they'll grow and increase the muscle mass and reduce the fat. So that also can be done for the second case post craniopharyngioma surgery and radiotherapy. So those are the things that we have in our armamentarium. I think we ran short of time, and I thank all of you all for listening. I don't know whether we have a question and answer session now. We have time.
Have 1 or 2 burning questions. I think everyone is now, yes. So thank you very much for the panel, for the interesting cases. And now we know how complicated this disease of obesity is. And I would like to thank Dr. Atri Wannayaka for that interesting case selection, and Dr. Manilka Sumanadilaka and Dr. Chatur Javardhana for that interesting discussion. If you have questions, both of our resource persons are at the NHSL endocrine unit. You can drop in and ask questions from them at any time. So let us show us our appreciation by usual manner. I think there's a token of appreciation to be distributed.
To formally recognize the invaluable contributions of our resource persons, I would like to invite Vidya Jyoti, Professor Prasad Katlanda, President of Ceylon College of Physicians, to present the letters of appreciation to the distinguished resource persons. Dr. Manilka Sumanatilaka, Consultant Endocrinologist, National Hospital of Sri Lanka. Dr. Chatur Jayawardena, Consultant Endocrinologist, National Hospital of Sri Lanka. Dr. Atri Wannayaka, Senior Registrar in Endocrinology, National Hospital of Sri Lanka. Thank you, sir.
let's move on to the second case discussion. So it's again a fascinating topic, the advances in osteoporosis. So I'll invite Dr. Hashini Seranayaka to discuss the cases, Senior Registrar in Endocrinology. And I would like to invite two of my colleagues, Dr. Dulani Kottahachi. She has done many research in osteoporosis, especially in patients with thalassemia. And I would also like to invite Dr. Chandrika Subasinghe. You know, when patients... Okay, so we'll start.
Thank you, sir, for that kind introduction. So the second session for the day would be advances in osteoporosis. So without further ado, I will go to the case. So our patient is Mrs. M, a 70 years old female who was a diagnosed patient with rheumatoid arthritis and type 2 diabetes mellitus with a history of long-standing steroid use because of the rheumatoid arthritis. And she presented us with the worsening of lower back pain for 2 weeks duration. But there was no any family history of previous fractures or any family history of fractures. And she was menopaused at 48 years of age. So in the examination, she was a thin-built lady, but she was not pale, with a BMI of 19, and there was a lower spinal tenderness, and she had a rheumatoid arthritis deformities in her hand, and the blood pressure and the pulse rate was normal. So we have done a DEXA scan. So you can see there's in the spine there's a reduction of BMD and the T scores are very low, and compared to the L1, L2 and L3 vertebrae, there was significant discrepancy in the L4 vertebrae with the T score and the BMD. So there is more than one standard deviation discrepancy in the this DEXA scan in the spine, mainly in the L4 vertebrae. So in that case, we have to find another secondary cause for this BMD discrepancy. This can be due to a fracture. We have excluded the L4 vertebrae in the second this DEXA scan. Still the T-score and the BMD score is still low. And we have done the femoral neck, both right and left hip DEXA scan also available here. Same as the spine, it also showing very low T-score and the very low BMDs. So in this patient, with this very low T-score and the low bone mineral density, this patient is having severe osteoporosis with very high risk of fracture. So we have done an X-ray as it is showing wedge fracture at L4 and others vertebrae showing osteopenia. So this is the investigation we have done, some basic investigations and some other investigation to rule out the secondary causes. So this patient already having multiple risk factors to become osteoporotic. So the full blood count, ESR and the renal functions were still normal, and her corrected calcium phosphorus were also normal, and there was mild rise in ALP. Vitamin D level was 27 and there's a mild deficiency, and the thyroid TSH was normal. So this patient with severe osteoporosis with a fracture. So she is basically a candidate for an anabolic agent, but in our settings with poor resources, we have managed her with IV bisphosphonate, zoledronic acid, and we have given calcium and vitamin D supplements. So this is our case. Dr. Dulani Kottahachi, consultant endocrinologist, will be discussing the thank you, over to you, madam.
Thank you, Hashini. So we have a case now where we see in our ward setups, we see patients with either fractures in the femur or in the spinal fractures. And now we have to manage this patient with fractures. Aim of management is to reduce further fracturing of this patient and to stabilize her BMD at currently and improve it in the coming years as well. So for these patients, just to talk a bit about osteoporosis, it's a progressive systemic skeletal disease with low bone mass, and there'll be always deterioration of the microarchitecture of the bone tissues, and because of that, there'll be increased bone fragility with increased risk of fracture. So always the bone formation and resorption will be in imbalance, where the bone formation will be outweighed by the increase in bone resorption. I'll be not going into pathophys. And this is relatively excess of osteoclastic function, and fractures of spine, hip, and forearm are the commonest fractures we see. And in postmenopausal age, this is mainly due to loss of estrogen after menopause. So you can see the osteoporotic bone, how thin the bone is, the defective mineralization. So how is this a public health problem? Because 50% of women and 25% of men above the age of 50 will have a low trauma fracture during their lifetime. So when you have a hip fracture, mortality will increase by 25% within a year. And more than 50% of hip fracture patients will never return to their original life as before as well. So we are dealing with a public health problem with osteoporosis, which is a silent disease. That's what we see in our patients. They just come and have a fracture, and then we are dealing with them. But we have not looked for them. We have not looked for causes. We have not screened them. So I think in Sri Lanka, we are way behind managing our osteoporotic patient, and we have to be vigilant in how we screen and manage our patients. So how do we screen for osteoporosis? Is by doing this dual energy X-ray absorptiometry or DEXA scan, which is a very simple scan of 1/10 of X-ray radiation. So very minimum radiation, very easy to do as well. So who should have a bone density is any woman aged more than 65, man above 70, postmenopausal women from 50 to 69 with clinical risk factors, adults who have had a fracture after the age of 50, and adults with other conditions like rheumatoid arthritis, taking glucocorticoids, or low bone mass should have a DEXA scan. So risk factors, there are major and minor. So major risk factors for osteoporosis is a history of fracture as an adult, fragility fractures, being Asian postmenopausal, low body weight, smoking, and being on steroids for more than 3 months. Even the slightest dose of 2.5 can increase your risk of having a fracture. So especially in elderly, the visual problems, estrogen deficiency at an early age, early menopause have a lot of effect on the bone, dementia, poor health, falls, low calcium intake, lifelong calcium intake being low, low physical activity, and you can see even alcohol have an effect, major effect on the bone as well. So there are medical conditions which are associated with osteoporosis. So we have to be aware when we are dealing with patients of medical conditions, whom should we screen for osteoporosis as well, especially patients on COPD, Cushing's, 18 disorders, hyperparathyroidism, hypophosphatemia, irritable bowel syndromes, rheumatoid arthritis, diabetes, multiple sclerosis, multiple myeloma, stroke, even thyrotoxic patients, and even patients with hypothyroidism, we've been overtreated as well. And vitamin D deficiency, liver diseases, you can see the spectrum. So all of these patients are at risk of developing osteoporosis. Are there drugs? Yes. Anticonvulsants, especially glucocorticoids, as I said, high doses of thyroxine, aromatase inhibitors we use for breast cancer treatment, even Depo-Provera, which we use for contraceptive, has an effect on the bone. It's a bad effect. So when we do a DEXA scan, is that only method we can diagnose osteoporosis? One, yes, it is. One method is T-score below 2.5 at the lumbar spine, femoral or total femoral, proximal femur, or even 1/3 of the radius. If the score is less than 2.5, we can diagnose. Even by having just a fracture, low trauma spine or hip fracture, regardless of the BMD, we can diagnose them of having osteoporosis. With the DEXA fracture, if the T-score is between -1 to -2.5, with the fragility fracture, still we can diagnose them with osteoporosis. And also by having a fracture risk score. Even if you have a T-score between -1 to -2.5, and your fracture probability is high depending on the country-specific thresholds, which I'll talk in a bit, you can still diagnose osteoporosis. So you know, just not one method of diagnosing osteoporosis. All of these methods can be used for this. So when we do a DEXA scan report, you've seen now few. We have a spine and we have a femur. So when you have a DEXA report, first thing you look at the demographics, the patient is correct, the age is correct, and all that. And then you look at the positioning of the spine, because unless you know the correct positioning, you won't be able to interpret the DEXA scan. And when you look at the DEXA scan, it should have from T12 to L5, and the bone mineral density should go from lower to higher value from L1 to L4. So we take L1 to L4, and there should not be a discrepancy of more than 1 T-score among the adjacent vertebrae. So if you have like that, the case we had, we should think of a secondary cause why there's a discrepancy. It could be a fracture, it could be osteoarthritis changes, spondyloarthritis changes, bone formations there, artifacts can be there. So there we have to think about it. So when we have a report, there are two things we have to look at. We have to look at the bone mineral density, and we have to look at the T-score. Why is there Z-score? Z-score is for especially premenopausal women and men and in children to look at the bone density. So when we take out the femoral neck, we look at the total femur and we look at the neck as well. We don't take the Ward's triangle for diagnosis of osteoporosis. So when you see, this is age into the BMD, and you can see on the right hand side the T-score. This is how we look at. So T-score is compared to the younger population. You compare yourself with the younger population of women, and according to your country-specific race, if there is your country-specific BMDs, you compare yourself with the younger generation. And Z-score, you can see we compare with our own age, how our bone densities are with the current age you're having with the same gender. So criteria for diagnosis, obviously normal is less than 1 of T-score, osteopenia is -1 to 2.5, and osteoporosis is -2.5 above. And this is the T-score is the number of standard deviation below or above the average BMD value for young normal adults of your own population. So why do we think about osteopenia? Because most fractures, we talk about osteoporosis, but as I said, even if you have osteopenia on your DEXA scan, you're more likely to have a fracture than you've had osteoporosis. Because you can see most fractures occur in the range of osteopenia. So there is a fundamental problem where we diagnose these patients wrong. Just having osteopenia, say, okay, you have osteopenia, your bones are pretty much safe, which is not. So we have to be careful when we interpret our patient's DEXA scan with the clinical situations. So how do we assess on the absolute risk by using FRAX score? You must have heard about FRAX score. FRAX score is used for patients where we are unable to directly diagnose osteoporosis to look at their fracture risk in the future. It is called a 10-year fracture risk model and 10-year fracture probability, and it assesses the likelihood of breaking a bone over the next 10 years, right? And it is very important in deciding treatment with patients with bone mass or osteopenia. So if you have a patient with osteopenia, you have to use the FRAX model to decide their risk of fracture. So if you just type in FRAX score, you will get this page, and you can select Asia, and you can select Sri Lanka as well, fortunately, because of Professor Sarath Lekamwasam, and you have to enter these criteria to the patient, the questionnaire, age, you have sex, weight, height, previous fracture, parental fracture, smoking, glucocorticoids, rheumatoid arthritis, secondary osteopenia, alcohol, and you can enter the BMD. And if you even don't have a BMD, still you can go ahead and calculate FRAX as well. So you can see in the bottom, you'll give a risk, whether it's a major osteoporosis fracture risk or a hip fracture risk. They will assess. This is kind of a model where we can use, right? So this is what we use. So what are the other investigations we should use for patients with osteoporosis? I think you've seen some of the investigations we have done. That is to look for other secondary causes of osteoporosis. We do the standard the bone markers, and we do the thyroid functions. We look for multiple myeloma, and we look for hypogonadism. You can see we look for hypercalcemia and celiac panel in patients where we need to go ahead and look for other causes when you really are unable to find any other cause. Even for Cushing's, we have to exclude. So let's talk about what is the treatment threshold. So we have done FRAX, done investigations, and we are looking for secondary causes as well. What is the treatment threshold? Treatment threshold is when a woman with a prior fragility fracture should be considered for treatment without further need for assessment. Can we do that? Although the BMD measurements is appropriate, that we use that in DEXA scans as well in the younger postmenopausal women. So we can use this threshold in younger patients, also in men, where we are kind of basing on the probability of major osteoporotic fracture risk. This is not just FRAX scoring. So this is kind of a country-specific threshold where you can see this age in x-axis and the risk of fracture on the y-axis. Depends on the country, and you can see patients, if you choose your age and you choose your fracture probability, you can decide whether you are going to treat or you are going not to treat, or just to observe patients and just give lifestyle interventions depending on your fracture probability. So this is different to each country and region. Let's talk about management now. So we have done the investigations, and we are now ready for management of our patients with a vertebral fracture who's 70 years, a diabetic rheumatoid arthritis patient who was on steroids with high fracture, high risk of osteoporosis. So main aspects are the universal bone health recommendations, and also drugs we need to be thinking of in our patient as well. So what is this universal bone health recommendation? That is, we have to maintain adequate calcium and vitamin D. If it's a smoker, we have to ask him to stop smoking, avoid excessive alcohol intake, and do regular weight bearing and muscle strengthening exercise. So you think for a minute, do we ask to do exercises in a patient with osteoporosis who are at high risk of fracture? Yes, we have to let them do exercises depending on their suitability. We have to assess them, their muscle strength, and then recommend them exercises to increase their muscle mass and their bone as well. And also in an elderly, we have to prevent falls as well. So how much of calcium and vitamin D should we recommend for these patients? You can see depending on the age, so let's say a woman of 51 to 70, you can see usual calcium intake should be around 1,200 milligrams per day. And there's an upper limit of safety as well. So vitamin D from 600 around to 1,000 per day. And safer upper limit per day is 4,000 per day. And can see requirements change according to age as well. But usually the upper limit of vitamin D is around 4,000 per day of vitamin D, and safe upper limit would be to have around 2,000 units per day of 1,000 to 2,000 around per day. So calcium, actually, when we give calcium carbonate and calcium citrate. So calcium carbonate had 40% of calcium and need gastric acid for absorption that should be taken with meals. And calcium citrate has 20% of calcium content and don't depend on the gastric acid for absorption and should not exceed more than 500 to 600 per dose. That's for maximal absorption. And if the daily requirement is more than 600, we should divide the doses as well. And we should always assess the patient's calcium and vitamin D before starting treatment, especially for patients with osteoporosis. I know it's very expensive to test the vitamin D levels, but at these cases, we do not have a choice but to do it because we need for them to be in good bone health in the future as well. So we look for 24 urine calcium collection to assess the adequacy of calcium intake and absorption in the coming years. We can always do that to see whether we are giving excess calcium to the patients. So vitamin D, serum 25 hydroxyvitamin D is measured to assess the vitamin D status. An optimal level for osteoporosis patient is around 30 to 50 nanograms per ml. So try to keep the levels around 50 for patients, and daily doses has been hypothesized to be more closely replicating the normal serum levels, and high dose concentrations. We sometimes give larger doses with boluses can induce 24 hydroxylation, resulting in inactive vitamin D as well. So daily dosing is always better than giving larger boluses. If you have a deficient patient with vitamin D, so there are ways we can replace this. Either we treat with 5,000 units daily for 8 to 12 weeks, or 50,000 units of vitamin D2, D3, you can use both. Give once a week for next 5 to 8 weeks to achieve the level more than 30. Then we go for maintenance therapy of 1,000 to 2,000 of vitamin D3 daily. So higher doses might be required by patients with obesity, malabsorption, and those on medications affecting the metabolism of vitamin D as well. So as I said, it's very important these patients stop smoking alcohol to increase their bone strength, which can associate with reduced calcium absorption and increased risk of falls as well. As I said, the exercises matter here. So children, to attain peak bone mass, we need to advise them for exercises, and weight-bearing exercises are the walking, jogging, stair climbing, dancing, and tennis. So you can see swimming and cycling are not here. They are not weight-bearing exercises, which will not increase your patient's muscle weight-bearing, the muscle strength, or the bone strength. Muscle strengthening exercises are weight training, and resistant exercises such as yoga can be done in these patients and should be evaluated specifically for before initiating these patients. We need to have an assessment because they are having a high risk of fall and fractures. See, very important, we prevent falls as well. So I have seen many patients, they come back to it, we give treatment, we give calcium, we give vitamin D, we give more anti-resorptive therapy, but they come back with a fracture because it's just fallen inside their house or outside their house because we have not tried to prevent falls as well. So it is very important. So how can we prevent falls? One is to exercise to improve the muscle strength and balance. And if they have visual impairment, we have to correct it. And correct the vitamin D deficiency is very important for increasing their muscle strength. And we have to reduce or replace medications that can cause dizziness, like even diuretics. Sometimes alpha blockers can be reduced. And also we have to correct the fall hazards at home and work environment. Sometimes slippery floors, slippery mats, the wet washrooms. We have to advise them for dry washrooms. So these are things, little things, but really matter for their management in the future. So what are the indications for treatment for these patients with osteoporosis? If you have a patient with osteopenia, with a history of fragility fracture of the hip or spine, we can treat these patients. We have to treat these patients. If you have a patient with T-score less than 2.5 or lower in the spine, femoral neck, total hip, or 1/3 of radius, this is indication to treat. If you have a patient with T-score between -1 to -2.5, with a FRAX 10-year probability of major osteoporotic fracture more than 20%, and 10-year probability of a hip fracture more than 3%, that's for US population, we should ask them to get treatment for osteoporosis. So what is the cutoff point for Sri Lanka? We'll talk in a while, because there's a category called very high fracture risk. So we diagnose osteoporosis. If they have a fracture, we say it's severe osteoporosis. So there's a category with very high fracture risk. So what is this very high fracture risk category? A recent fracture within the last 12 months, fractures while on approved treatment for osteoporosis, multiple fractures, fractures while on drugs causing skeletal harm like long-term steroids, very low T-score, less than -3, high risk for falls or history of injurious falls, and very high fracture risk probability by FRAX, that is major osteoporotic fracture more than 30 and hip fracture risk by more than 4.5. So all these patients are at very high risk of future fracture. So country-specific threshold for Sri Lanka is 10-year fracture risk of 9. You can see it was 20 for US, it's 9 for us. And 10-year hip fracture risk is 3% for Sri Lanka, where it was 4% in the world. So we have a lower threshold for fractures, and this is made available for us as well in many researchers as well. So this is the country-specific threshold for FRAX treatment threshold for Sri Lanka. 9% for major osteoporotic fracture and 3% for hip fracture. So that is a high risk category. The high fracture risk, that is a very high risk fracture. Now this is the high fracture risk. Are patients who are diagnosed with osteoporosis but are not at very high fracture risk are considered as high fracture risk patients. So how can we treat these patients? So what are the evidence for fracture reductions? Can we use all these medications for all these fractures? No. Some are for vertebral fracture risk reduction, some are for non-vertebral, and some are for hip fracture, and some are for all. So we have to have a bit of idea which drugs work on which fractures better. So you can see the calcitonin, raloxifene, and libandrate work very well on vertebral fractures, but not on non-vertebral fractures. Whereas alendronate, risidronate, solidronic, denosumab, and teriparatide works well on vertebral and non-vertebral fractures. But you can see hip fractures, the risk is not very much improved with teriparatide. So these are the FDA-approved medications we have. We can use for postmenopausal, glucocorticoid-induced, and for males. You can see the glucocorticoid-induced osteoporosis and males. We can use the alendronate, risidronate, solidronic acid, and denosumab can be used for only postmenopausal and males, not for glucocorticoid osteoporosis. And teriparatide can be used for all three of these types of patients. So we have to select the category of medications where we have to use for our patients. Bit about oral bisphosphonates, which is the commonest we write in our ward setting, in our clinic settings. So administration is important. I think you all know about this. Should be taken first thing in the morning, 1 hour prior to your food. And they should not lie down to prevent having esophagitis, and with a full glass of water. And they can walk, they can do their day-to-day work, but not lie down. So some just keep sitting for 1 hour. You don't have to advise that. They can do their normal day-to-day work. The IV zoledronic acid is the IV bisphosphonate. Either 4 milligram or 5 milligram infusions are there. So in the ward setups, we have the 4 milligram, but 5 milligram is where most of the studies are. Should be given as an IV injection with normal saline over more than 15 minutes. Should be given as a yearly infusion for 3 years duration. And we can give it to up to eGFR of 35, and we have to be cautious in renal failure. And it is ideal for patients with DI contraindications to oral formulations and poor compliance to oral therapy. And compared to oral and IV, IV has a better efficacy compared to the oral, and it should be considered for patients with very high risk of fractures. So you can see the duration of treatment, very important. We write it and we ask them to keep going. They sometimes stop at 1 year, stop at 2 years. They continue for even 7, 8 years. So we have to tell them the duration at the onset. You'll be on this medication for 5 years. I've never seen that being told to patients. So it's our responsibility. You tell your patients, your patient will be on this treatment for 5 years. If it is IV, we give for 3 years. And then we reassess you for the further need or discontinuation of treatment. And when you stop even this treatment, there is an effect, because this effect will go on for some more time than where you have stopped, discontinued, right? So drug holidays are given specifically to prevent what is called atypical femoral fractures, stretch fractures, which can happen at the femur. So you might think we give this drug to prevent a fracture, and we cause a fracture in the meantime as well. Yes, because these fractures can increase. You can see cortical thickness of this femur can get increased by giving high doses. Inadequate. Sometimes it's always given more than the required duration. So we have to always ask patients for if you have any thigh pain, which is excruciating pain on long-term bisphosphonate therapy patients, whether to do a X-ray or not of this femoral, you can see femur, we can decide. So this is a kind of a beak, like you can see in the X-ray as well. Cortical thickening can happen. So we have to always assess their fracture risk by in intervals of 2 to 4 years. Denosumab is one of the most commonly used drugs around the world, where unfortunately we don't have our hands on at the moment, only in the private sector, but which is also off-label at the moment. So it's a human monoclonal IgG2 antibody given as a subcut injection every 6 months. And this has an effect on bone remodeling, reflecting on the bone turnover markers. But the thing is, the effects reverse just after stopping the treatment at 6 months. So there'll be no ongoing benefit from the drug if you stop at just after 6 months. We have to continue to give it at 6 monthly intervals. So we don't recommend drug holidays or treatment interruptions when the patient is on denosumab, and we have to assess the fracture risk after 5 to 10 years in these patients. So denosumab is a rank ligand inhibitor that can inhibit the osteoclast formation, functions, and survival as well. So what are the side effects of denosumab? They can have hypocalcemia and the inflammatory disorders like the osteonecrosis of the jaw, atypical femoral fractures are very rare compared to bisphosphonates and can be given for patients with renal impairment. That is very important. So irrespective of the EGFR, we can give this treatment to increase their bone density. So selective estrogen receptor modulators, the raloxifene, is very important for prevention and treatment of osteoporosis in postmenopausal women. If you can remember the first slide I showed you, it mainly have an effect on the vertebral column, the vertebral fractures, and that is the tissue. Its action is the tissue selectivity activity. Acts as an estrogen agonist on the bone, but estrogen antagonist on breast and uterus. And it can reduce the fracture risk by 40% in the vertebral fractures, but there is a lesser effect on the hip and the non-vertebral fractures. So this can be used for postmenopausal women, but effect is lesser than having hormonal treatment or estrogen therapy. Can we give estrogen therapy for patients with postmenopausal for bone prevention of osteoporosis? Yes, we can. So we have to consider all other non-estrogen therapies first. If we can't give them or contraindicated, then we can think of giving the hormonal treatment for postmenopausal women as to control their vasomotor symptoms, the postmenopausal symptoms, plus increase their bone strength as well. So we always prescribe them when we believe that the outweigh of the risks is outweighing the specific need of the patient, need of the medication. So when do we consider HRT for osteoporosis treatment? When the patient is under 60 years or less than 10 years post-menopause at low risk of DVT, those whom bisphosphonates or denosumab are contraindicated or not appropriate, when they have bothersome vasomotor symptoms, without contraindications, without history of prior MI or stroke, without breast cancer, and willing to take the hormone treatment for some time. So these patients can be considered for HRT as treatment for osteoporosis as well. So these are the new kids on the block, the teriparatide and abaloparatide. So these are PTH and PTH-related protein analogs. So what are they? So PTH, we know, is a hormone which increases osteoclastic activity, which increases your calcium. So why are we giving a medication, a hormone, which can increase osteoclastic action? It's a vice versa. When you give this intermittently, it increases bone formation, right? So treatment of osteoporosis, especially the postmenopausal women at high risk of fracture, this is an indication for teriparatide and abaloparatide, specifically patients with previous fractures who are not getting control with the usual treatment, multiple risk factors for fractures, extremely low BMD, and which are failed or intolerant to previous treatment. Like our patient had a T-score of minus 4.7. It's a very high risk fracture. So this patient would have, as Hashini said, would have been better off with the anabolic agent first, then going with the anti-resorptive. First we increase the bone formation and then we continue with the anti-resorptive medication. So it would have been ideal for our patient. And we can also use this for treatment of primary or hypogonadal osteoporosis in men at high risk of fractures as well. So the main mechanism of action is stimulating osteoblastic function, increasing GI calcium absorption, and increasing calcium, renal tubular reabsorption of calcium as well. And it enhances bone turnover by initiating greater bone formation. That is where the drug is a bone anabolic agent. What's the efficacy of the drug? So 74% reduction in the risk of vertebral fractures, 39% reduction in non-vertebral fractures. So hip fracture reductions were not statistically significant, but there is a trend that it increased the bone strength. But the thing is, when you stop the treatment at 1 year, that effect will wane off. So we can use this maximally for about 1 or 2 years. So adverse effects would become as hypercalcemia, and there's a very rare risk of having osteosarcoma noted in rats. But since the introduction of the drug, there is only one case report so far for osteosarcoma of the bones. They can have leg cramps and dizziness, which are very minor side effects. And this is the latest on the new cards for patients with osteoporosis, romosozumab. This is a fully human monoclonal antibody to sclerostin. This is a wonder drug where it increases bone formation plus reduces bone resorption as well together. So it has dual actions. How does it do that? So sclerostin is enzyme where it binds to the Wnt receptor and inhibits the differentiation of precursor cells into mature bone forming osteoblasts. So when you block this sclerostin, you increase the binding of osteoblasts and increase the activity of osteoblasts, and also have reduction in osteoclastic activity. So both by bone modeling and remodeling both. So this is a wonder drug, should be given as a subcut monthly injection for 12 months duration. And the side effects would be, they have been found to have increased risk of myocardial infarctions and stroke in elderly patients. So we do not use this in patients who've had a stroke or cardiovascular event. But there are newer studies showing it is not so, but it's a warning that we do not give these patients with these risk factors the romosozumab. So this and the teriparatide and abaloparatide would have been ideal treatment for our patients with very high fracture risk, and then we can use this. So I've talked about all the drugs possible here for us. So what can you use for your patient? This is how you decide. So initial therapy for patients with high fracture risk, you can either use bisphosphonate, oral or IV. You can use denosumab, and you can do residonate as well. So initial therapy with patients with very high fracture risk, as our patient, so abaloparatide, denosumab, rosuzumab, teriparatide, zoledronate. The first line would be the PTH analogs, or the romosozumab. In failing, we can give the IV, would be better than the oral bisphosphonates. And patients requiring drugs with specific efficacy for vertebrae, then you can use the ibandronate or relaxivine for vertebral fracture risk reduction. So these are how we choose your patients, how to use and what not to use for patients. So when we use these drugs, how do we monitor treatment? It's very important. We can either do the DEXA, that is in every 1 to 2 years. We don't do it just after 6 months. We at least minimum of 1 year we have to wait. That is for very high risk patients. Either we can wait for 2 years for moderate risk patients, and we can use the spine, hip, or 1/3 of radius. And we monitor the serial BMDs, and the follow-up should be done ideally with the same DEXA scan. Can we use the bone turnover markers? Yes, that is one good way of assessing compliance. So you don't have to wait for 1 year for DEXA. You can do it at even 6 months to see whether your patient is taking the medications. So if you're taking the medications, anti-resorptive medication, there'll be reduction in bone turnover markers. Where if you're taking anabolics, that will be increasing your bone turnover markers. You can look at the efficacy and especially the compliance of treatment, whether your drug is working or not. You can assess by doing the bone turnover markers. Last few slides on the treatment failure. What is treatment failure? Recurrent fractures or significant bone loss while on treatment. You have given treatment, but still the patient is having a fracture. If you have a single fracture while on treatment, it is not suggestive of treatment failure. You have to remember that, just having one fracture while on treatment. Because when we give the treatment, it requires some time to increase the bone strength. It doesn't increase overnight, does not increase over 6 months, it takes years. So while on treatment, if you have one fracture, it is not treatment failure. If you have more than 2 fragile fractures, then it's suggestive of treatment failure. So this is called sequential therapy. In treatment of osteoporosis, you can see depending on the case scenario, we can decide on the choices. We can always start with anabolic drugs and go into anti-resorptives. This is the best way now. It's been found to have high-risk patients. either if you are unable to start on anabolics, you can start with antiresorptives and continue, and you decide on how you're going to change. It's not going to be just one drug for your patient. We just start on alendrin and we do go on forever. No, we can always combine, change, go sequentially for management of your patients with osteoporosis. So I'll now hand over to Taranga for the panel discussion.
Thank you, Dulani, that comprehensive lecture. I would like to invite Dr. Chandrika Subhasinghe to the stage. Gentlemen, ladies and gentlemen, when we have problems with osteoporosis, patients come to us, the endocrinologist. So when we are stuck with patients, we go to Chandrika because she's so good at managing patients with osteoporosis. So I'll start where you stopped, Dulani. So you have these wonderful drugs, and we give bisphosphonates to our patients. When we stuck, when the patient get treatment failure, when they get fractures. So what is the solution we have in Sri Lanka?
Sorry, can you repeat?
Yes, so we commonly give bisphosphonates to our patients. So, but the problem is sometimes we get treatment failures. So we have these wonderful drugs, but what can we do in patients our setup?
Yeah, so the treatment failure first, most of the time the reason for treatment failure could be the compliance issues, especially when the patients are on oral bisphosphonates. Because of the GI side effects, they are not compliant with the treatment. And also if we start with the very high fracture risk, and there is a chance the patient may not respond the way we expect, because as we know now, they recommend to start with anabolic treatment if available for such patients. So we have to monitor the patients clinically and with the BMD to see whether they have features of treatment failure. As Dr. Dulani mentions, more than 2 flagellate fractures, or with fracture or without fracture, there's BMD decrease, or if available with the bone turnover markers. So especially if the patient is having BMD decrease more than the least significant change, in that case, we have to think whether there is a treatment failure. Plus, clinically, we have to assess why. What are the reasons? Whether there is a secondary cause, untreated vitamin D deficiency, or patient is not taking the drug, or there may be undiagnosed secondary cause. So, find out that if that has not been found out at the very beginning, and then treat the cause. And otherwise, you may have to go for other options. If the patient is on oral, may change to IV bisphosphonates or denosumab, or if available, changing over to anabolic therapies also, if available, is option. But if available, to start with it for the high risk, very high risk patients is preferred. So those are the things we could do, and always prevent falls, and calcium and vitamin D supplementation, and also muscle strengthening exercise. And if the patient is having sarcopenia, gaining weight with protein supplementation is also important to prevent treatment failure.
Thank you, Chandrika. Wonderful explanation. So any questions from the audience?
Not a question, actually. Thank you, Chandrika, for stressing upon this importance of muscle strengthening exercise and the protein supplementation. And I have noticed, and particularly in patients who fail, if you really get them into a good course of program of muscle strengthening and bone strengthening with light weights and so on, with fortification of protein intake, you can really have a good change. Thank you for mentioning that.
You mentioned a term called least significant change. Sometimes, patients come with DEXA reports and ask the doctor, is it like, am I improving? So what is this word?
So least significant change is that is used to describe the BMD change, bone mineral density change, in the follow-up DEXA scans. So in simple words, that means whether this change is real. If the BMD change meets or exceeds the least significant change, that means there's a real change in the bone mineral density in the follow-up DEXA scan. So mainly we use the least significant change in the follow-up if there is when we compare, if the BMD remains same in the follow-up scan or if it increases, then we are happy. But if the BMD decreases, then we are worried whether we are going for a treatment failure or whether there is any other cause why the BMD is not improving. When the BMD decreases, we need to know whether it is real or just a change in the scan report or the BMD measured in 2 scans. To know that, we need this least significant change that has to be calculated for every machine for the operator separately and take a mean value. And so it can be given as gram per square centimeter or as a percentage. And we have to know the least significant change for each DEXA machine and for the operators who are using that. And if we know that, we can interpret, we can know whether this change is real and take decision based on that.
Any other questions? So one area we couldn't touch, I think, was, it's a wonderful presentation. Only thing that it was not relevant to the case that some of our patients are on steroids, right? So there's a thing called glucocorticoid-induced osteoporosis. So could you tell us a little few more words of that?
The glucocorticoids, we know it causes significant bone loss in any patient, even at very low doses, like doses more than 2.5 milligram prednisolone equivalent doses. If you use in long term more than 3 months, higher the dose, higher the bone loss. And initially at 6 months, there will be a rapid decline in the BMD, and with the continued use, there will be steady fall of BMD. And mainly it is caused by indirectly through sex hormone suppression, and also directly by affecting the differentiation and the apoptosis of osteoblast and osteoclast, etc. And also steroids affect the calcium metabolism. So any patient, adults who are on steroids long term, even more than 2.5 milligram prednisolone equivalent doses, we have to assess them for fracture risk clinically, and also using BMD and the PRAC scores, and treat appropriately, because there is no time. I'm not going to elaborate on that, but important thing is, even at very lower doses, more than 2.5 milligram of prednisolone, if they are on long term and if they have other risk factors, we have to be very concerned and start treatment early as possible, because the rapid decline will be in the first 6 months of glucocorticoid use.
Thank you, Chandrika. So unfortunately, we have run out of time. So that makes the end of the first session of the case discussion. So I would like to thank Dr. Hashini Seranayaka, Senior Registrar in Endocrinology, for that wonderful case, and Dr. Dulani Kottahachi, my colleague, for that excellent explanation on management of osteoporosis, and Dr. Chandrika Subhasenka for her insights.
Thank you, sir. Now, to formally acknowledge the contributions of our resource persons, I would like to invite Dr. Dimuthu Muthukoda, President of the Sri Lanka College of Endocrinologists, to present the letters of appreciation to the resource persons. Dr. Dulani Kottahachi, Senior Lecturer and Consultant Endocrinologist, Department of Physiology, Faculty of Medicine, University of California. Dr. Chandrika Subhasenka, Consultant Endocrinologist, Colombo North Teaching Hospital, Ragama. Dr. Hashini Seranayaka, Senior Registrar in Endocrinology. Dr. Tharanga Samarasekara, Consultant Endocrinologist, District General Hospital, Negombo. Thank you, Madam. The next half of the discussion will be moderated by Dr. Newmal De Silva, Acting Consultant Endocrinologist, National Hospital of Sri Lanka. Over to you, sir.
Thank you very much. So we'll move on to another very important two topics. So the first will be on endocrine hypertension, again another very common problem in endocrine practice. So first let me invite Dr. Himansa Ranawaka, Senior Registrar in Endocrinology at National Hospital of Sri Lanka, to present the case. Also, I would like to invite two prominent endocrinologists, Dr. Udita Bulugahapitiya, Consultant Endocrinologist at National Hospital of Sri Lanka, and Dr. Sunali Gunatilaka, Consultant Endocrinologist at National Hospital Kandy, as our resource persons.
So good afternoon, everyone. So this mini session will be on endocrine hypertension. It will be an interactive case-based discussion where I will be presenting two cases, and from the initial presentation up to the definitive management, and our expert panelists will be giving their input along the way. So without further ado, case 1. Mrs. R, a 33-year-old developmental officer who was married and from Colombo. In 2019, she was incidentally detected to have hypertension when she was 28 years of age. It was detected at a non-communicable disease screening clinic at her workplace. And she was started on nifedipine, 20 milligrams twice daily. But she was not on routine follow-up, and she was not extensively evaluated. Thereafter, in 2024 August, she was admitted with dengue fever, and she was detected to have hypokalemia, which persisted following the recovery of the illness. It was around 2.8 millimoles per liter, and there were no attributable gut losses, such as vomiting and diarrhea. On further questioning, she admitted to have salt craving, non-specific muscle cramps, easy fatigability, features suggestive of proximal myopathy, and blood pressure was not controlled despite 3 antihypertensives, namely losartan, nifedipine, and prazosin.
Yes. What would be the probable differential diagnosis for hypertension plus hypokalemia in this setting?
I think this patient has got resistant hypertension. That is the most important point here, because the patient is on 3 antihypertensives without getting the target control. So first thing is the patient has got resistant hypertension and also got hypokalemia. So when you have this combination, I think the first differential diagnosis would be the primary aldosteronism. And having said that, I think 40%, here you mentioned that 40% of patients can have normal potassium in primary aldosteronism, but some studies have shown even 60% will have normal potassium in primary aldosteronism. That means that you can't exclude having normal sodium and potassium does not exclude primary aldosteronism. So the second commonest cause is the secondary aldosteronism, mainly the renovascular disease, especially the renal artery stenosis, and also rarely renin secreting tumors. And also we need to understand that Cushing's can rarely present with hypertension and hypokalemia, but at that point usually Cushingoid features are very prominent and it's a clinical diagnosis. And Liddle syndrome is a rare syndrome, but also can present with hypertension and hyperkalemia.
Yes. So if we take sort of a holistic approach, what are the other non-endocrine causes that we need to exclude in this scenario?
Yeah, so if we take hypertension, the commonest cause is essential hypertension, and secondary hypertension accounts to a lesser percentage, and about like 10 to 20% of the whole population. And if we take the secondary hypertension per se, Again, the commonest cause is not endocrine causes. It is mainly in Sri Lanka and worldwide. It is renal causes, renal and renovascular causes. So like polycystic kidney disease, chronic kidney disease, glomerulonephritis, and renovascular causes like renal artery stenosis. And again, going down for coarctation of aorta are those causes of renal and vascular causes. And the ones that we forget or overlook are like obstructive sleep apnea. If you see obese patients who are having features of obstructive sleep apnea, about like 80 to 90%, if we sort out that, there would be a very good control of hypertension and maybe resolving of hypertension. And again, not to forget medications like NSAIDs, OCPs, and also recreational drugs and drug abuse can cause hypertension, and they account for secondary hypertension.
So keeping that in mind, we took further history. She did not have pigmented striae or ecchymosis suggestive of Cushing's. No family history of young onset hypertension, young cardiac events or strokes. She did not have episodic palpitations or sweating. There was no family history of hypercalcemia or thyroid malignancies, no history of flash pulmonary edema, renal disease or uremic symptoms, and no features suggestive of obstructive sleep apnea, and she was not on any further medications. On examination, her BMI was 24.8, which was overweight, and her blood pressure was 160 by 100 on both arms, and her pulse rate was 76 regular. She did not have clinical features of Cushing's, and she did not have a renal artery bruit. On the neurological examination, she had a proximal myopathy in bilateral lower limb proximal muscles. Power was 4 out of 5. Initial investigations were done, and her serum potassium was 2.6. There was a hypokalemia. Serum sodium was normal, 139. Magnesium was also within the normal range, 1.7, and corrected calcium was also normal. Spot urine potassium was 32, and TSH was in the normal range as well. In the ABG, pH was 7.48 with PCO2 45, PO2 95, and a bicarb of 28, which was suggestive of metabolic alkalosis.
Yes, so how do we interpret these initial investigations?
I think this patient has got very low potassium levels, 2.6. You can actually repeat that and confirm before you go ahead with other testing. Another important test is that spot urine for potassium, because it is more than 20 here, and actually suggests that there is a renal tubular potassium loss. I think better test of that is usually tubular potassium gradient is a better test to do, but spot urine for potassium is also quite a good test. And then if you look at the blood gas analysis, metabolic alkalosis. So when you have metabolic alkalosis with hypokalemia and hypertension, that suggests that this patient probably has got mineralocorticoid excess. That's what actually we can explain from whatever the investigations available here.
Yes. In this scenario, what should be the next investigation?
Okay, so as said, it's suggestive of mineralocorticoid excess. So if you look into the causes of mineralocorticoid excess, there is huge number of causes, and to identify them in a correct way and then to guide yourself, I think the next very best test would be to test the aldosterone and the renin amounts and the ratios, so that we can differentiate the causes according to their levels, whether they are high or low, or ratio is reversed, or whatever the outcome is.
So this patient underwent aldosterone renin ratio test, and her plasma aldosterone concentration was 53.6, and her plasma renin activity was 0.12, and plasma direct renin concentration was 1.4, and aldosterone renin ratio was 446.67. This was done while the serum potassium was 4.2.
So how do we interpret this ARR?
Yeah, actually, if you look at this, this test is actually quite expensive. I think there is no chemical pathologist in the audience, I suppose. So before you do that, actually, you must make sure that you're in the correct direction, unless you're actually spending a lot of money without any reason. So if you look at the plasma renin activity, that is suppressed, and if you look at the plasma aldosterone concentration is quite high. Now, if you look at this particular graph, you will see that the most important single test here is the plasma renin activity. If it is suppressed only, we have to think about primary aldosteronism. When the plasma renin activity is suppressed and when the plasma aldosterone concentration is more than 20, actually that is overt PA. There is no doubt about it. When you do that, when the plasma aldosterone concentration is less than 5, it is pretty unlikely that you are dealing with a PA. Between 5 to 15 is likely to be PA. Therefore, you need further investigation for testing. So our patient has got very high plasma aldosterone concentration and suppressed plasma renin activity. There is no doubt that this patient has got primary aldosteronism.
Yes, so we discussed about the importance of preparation. So what is the preparation for ARR?
So, like I said, it's very expensive and not all the centers do have this investigation. So, we have to be very selective. And when we prepare the patient, so that's why we need to prepare and select and make it correct at the first go. So, there are a lot of medications these patients are on, antihypertensive medications, because it's resistant hypertension and difficult to control. Therefore, we have to look at these medications, whether these medications interfere with the aldosterone and renin concentrations. Well, unfortunately, most of our antihypertensive medications do interfere with renin and aldosterone concentrations, either make them low or make them high. Therefore, we need to modify our antihypertensive regimes to agents which are not affecting the aldosterone or renin concentrations, and they are, like in the slide, prazosin or doxorubicin and verapamil group of calcium channel blockers and hydralazine. Now, we have prazosin and verapamil, although hydralazine is only in the private sector mainly. So we can switch our medications to this kind of medications, and duration is also important. At least 4 weeks, we have to stop spironolactone, eplerenone, and potassium wasting in diuretics. The commoner antihypertensives can be switched during the last 2 weeks of the test. Having said that, this is the ideal setup. But if you are unable to change over these medications in one of your patients, you have to keep in mind that you are able to interpret the test result while the patient is on this medication. So for an example, if somebody is doing the test while on ACE inhibitors, ACE inhibitors will reduce aldosterone concentration, slightly increase renin concentration. And you do the test while on ACE inhibitors, and if you get a result of renin very low, obviously the drug usually increases the renin concentration. If your result is very low, obviously it is PA, right? Likewise, the person who orders the test needs to identify the mechanism and interpret the test properly if the patient is on these medications.
Thank you. Yes. So we have had a positive ARR, but then what are the confirmatory tests for the primary aldosteronism?
Yeah, usually there are many confirmatory tests, but I think the most important point here is all the patient needs no confirmatory testing. Now, if a spontaneously patient has got hypokalemia and plasma renin activity is suppressed and your plasma aldosterone concentration is more than 20, I think you need no further testing for the confirmation. So I think it is important to understand that. The most common test that we use is the saline infusion test that you do after overnight fasting. Do it in the morning and you give 2 liters over 4 hours and take before giving as well as after 4 hours you do the aldosterone level. Now, if you look at that aldosterone level, if it is more than 8, that actually confirm your diagnosis of primary aldosteronism. If it is less than 6, you exclude. In between, of course, you need to think about whether this is going which direction.
Thank you, sir. Yes, so once we have established the diagnosis of primary aldosteronism, what are the different etiologies for primary aldosteronism?
So that is high aldosterone levels, obviously coming from the adrenal glands. So this excess aldosterone could be due to a lesion, a tumor, which is benign or malignant coming from the adrenal glands. So we call them adenoma or adrenal carcinomas. Or this could be the adrenal glands, both sides are being hyperplaced, like enlarged, and both the adrenal glands are secreting excess amounts of aldosterone. We call them adrenal gland hyperplasia. And rarely, sometimes you may get unilateral hyperplasia due to macronodular hyperplasia. So anyway, it could be an adenoma, carcinoma, or bilateral adrenal hyperplasia.
So, since this patient has biochemically proven primary aldosteronism, we went ahead with imaging. Her ultrasound abdomen, there was no significant abnormality. There were no suprarenal masses detected, and renal sizes were normal, and there was no difference between the two sides. Then she underwent CECT abdomen pelvis in the adrenal protocol. There was a well-defined uniformly hypodense lesion in the right adrenal gland, 24 into 19 into 16 millimeters in size. There were no calcifications or hemorrhages, and her non-contrast CT density of the lesion was 24 Hounsfield units. And her contrast absolute washout was 61%, and the relative washout was 49%. So this is the CT where you can see this lesion is the right-sided adrenal mass, pre-contrast and post-contrast in the two images.
Yes. So how do we interpret this CT scan?
So I think when you think about the primary aldosteronism, it is important that you do a adrenal protocol for the CT scanning. And most importantly, you look at the size of the tumor, you identify the size of the tumor, and then Hounsfield units. Because primary aldosteronism is usually lipid-rich tumors, and they are usually the Hounsfield units are lower, usually even can be less than 10. So I think most importantly, it is the plain Hounsfield units that we look at. Other things, when actually there is a problem of identifying this as a malignant or a benign tumor in a adrenocortical tumors and so on, then we can think about other washout and all that. But here, I think most important thing is the size and also the Hounsfield units, because lipid-rich tumors are having low Hounsfield units, and lipid-poor ones are having high Hounsfield units.
Thank you, sir. Yes, in this scenario, what is the place of interventional radiological procedures for localization?
Yeah, I think now this is also very expensive testing. I don't think that we should just go ahead with doing this testing without consulting the appropriate specialties. And more important thing is that all the patients need not to go ahead with this kind of procedure like adrenal venous sampling. So if the patient is less than 35 years and severe primary aldosteronism and spontaneous hypokalemia with plasma aldosterone concentration is more than 30, and those patients need no vascular involvement like testing. And also if the tumor is more than 1 centimeter, then actually you need not to go ahead with the adrenal venous sampling. Adrenal venous sampling is a complicated testing, so I don't want to go ahead and actually explain how we do it and how we interpret it. I think it always you must get with the specialist opinion for you to go ahead with this kind of testing.
Thank you, sir. Yes, moving on, what are the adverse effects of aldosteronism?
So we know that's why we are talking about aldosterone. High aldosterone obviously causes high blood pressures by increasing salt and water retention from distal and convoluted tubules. That's obviously known. But apart from that, aldosterone has this particular thing about this hormone. It causes inflammation as well as it promotes fibrosis. So it increases the reactive oxidant species, which will in turn causes inflammation, fibrosis, and many things in our organ systems. If you take the heart, it will cause fibrosis, inflammation, and cardiac remodeling, therefore diastolic dysfunction, heart failure, and many other changes in the cellular level. It's not only hypertension. And in the vessels, again, inflammation and vascular stiffening causes a lot of changes in the vasculature. And fibrosis of the kidneys causes renal failure. It might lead to renal failure and many other things. And also it has metabolic effects like it reduces the insulin sensitivity. So it's not only hypertension per se. It causes systemic kind of an inflammatory and fibrotic process, low grade, in the whole body.
So keeping that in mind, we did further investigations on the patient. And we wanted to exclude co-secretion of other hormones from the adrenal tumor. So we did oral dexamethasone suppression test, which was suppressed, so it was normal. And serum testosterone was 1.38 in normal limits, and serum DHEAS, which was again in the normal limits. And her serum creatinine was 0.7. 2D echo did not have any features of heart failure, and her fasting blood sugar was 106 in the impaired fasting glucose range.
What is the best management for primary aldosteronism?
Okay, so we have excess aldosterone producing lesion, likely a tumor most of the time. So we don't want excess aldosterone. So it's very simple. It's a surgical removal of the responsible lesion is the curative form of or the best way of treatment. Having said that, not all the lesions can be treated surgically, but if we know that there is unilateral lesion, adenoma or carcinoma or unilateral hyperplasia, we can take that part easily out, usually laparoscopically. And this is a very easy procedure. Surgeons are very expert in doing this, and that reduces the aldosterone levels. Now, when you do that, most of the time potassium becomes normal. However, if you look at the hypertension, the blood pressure series, about like significant proportion reduces, like improves the blood pressure. Some another proportion completely goes into remission, like, blood pressure normalizes. But another about like 30%, depends on the series, 20 to 30% sometimes remain with high blood pressures. However, the number of medications that they need is less. Now, why is that? Because of the changes that I told earlier, vascular changes, changes in the heart, which are kind of permanent. Now, these changes depend on the duration of that person having had hyperaldosteronism and whether it was very resistant at the very beginning before the intervention. So if the patient was on very high number of medications, it's very difficult to cure even after surgery. Likewise.
Thank you. So what is the place for medical management in primary aldosteronism?
When the surgical management options are not possible, or when the patient has bilateral disease, then we think about a medical treatment. When you think about the medical treatment, I think it's mainly the mineralocorticoid antagonist are the treatment of options. But first thing is to try and get the target control of blood pressure is the first thing to do, and also normalize your potassium. The best response would be with the spironolactone or epinephrine or with amiloride. Those are the drugs which actually really act on this process. And even if you look at the third or the fourth drug in resistant hypertension, best drug is going to be the spironolactone. That's why we had a lot of research on this matter. And if you can't achieve the target blood pressure with these medications, then you can think about other medications that we have shown below to get the target pressure control.
So this patient had a right-sided aldosterone-producing adenoma, and she underwent laparoscopic right-sided adrenalectomy, and her recovery period was uneventful. Preoperatively, she had blood pressure optimization with mineralocorticoid antagonists, ACE inhibitors, calcium channel blockers, and alpha blockers, and normokalemia was achieved with the spironolactone dose. Post-surgically, her spontaneous hypokalemia resolved without any oral KCl supplementation. Initially, she was on antihypertensives, but the requirement reduced. But the requirement also was able to be tapered off over 3 months following the surgery. And she is currently clinically well on follow-up. So we'll move on to case 2. Mrs. S, 38-year-old mother of three children from Batticaloa. In 2023, she has initially presented with chronic headache, which was there for 1 year, and she was detected to have hypertension. She had no history of hypertension during her pregnancies. The last was at the age of 25, and she presented for further evaluation in 2024. On further questioning, she admitted to have episodic headaches for 2 years, which were bifrontal headaches lasting few hours and pounding in nature. There were no sinister signs of increased intracranial pressure and no aura, vomiting, or neurological deficits. She also had episodic palpitations for 8 months duration, but it was not significantly associated with sweating. And she did not have history of angina or syncope. She denied profuse sweating in general, and blood pressure was controlled on losartan and nifedipine, but occasionally she had recorded spikes of blood pressure at her GP.
Yes. What are the probable differential diagnoses in this scenario?
Okay, now this is hypertension, episodic hypertension and episodic spells of palpitation. And obviously, when you hear this with regard to hypertension and palpitations, the first thing which comes to mind is pheochromocytoma. But we should not go straight away to this diagnosis. There are several differential diagnoses that you can think of. Obviously, panic attacks, anxiety can lead to episodic palpitations. And also, if you check, the blood pressure is 200 by 100. Right? And apart from that, sometimes alcohol withdrawal and maybe like illicit drugs like cocaine can give rise to similar kind of picture. And again, menopause in certain ladies, they come with palpitations, anxiety, sweating, as well as high blood pressure. And apart from that, if we concentrate on very rare endocrine causes, like medullary thyroid CA and systemic mastocytosis, carcinoid syndrome with spells can lead to this. And again, not to forget simple ones like hyperthyroidism. Again, they can have hypertension and palpitations, even though it is not usually episodic. Some people do come with episodic symptoms.
Thank you. Yes. So we discussed about pheochromocytoma. What is the typical presentation of a pheochromocytoma?
So, like I said, pheochromocytoma, that is a tumor which secretes excess catecholamines, adrenaline and noradrenaline, or epinephrine, norepinephrine. So these are adrenogenic and they cause stimulation of alpha-beta receptors. Then, as a result, they get palpitations and headaches and also sweating. Depends on whether it's adrenaline predominant or noradrenaline predominant, the symptoms differ. If it is epinephrine or adrenaline, it is episodic. Whereas if it is norepinephrine, it is more or less not episodic, it's more or less constant. They come with palpitations, headaches, and not to forget persistent tachycardia is again sometimes a catch where we can see these patients. And sometimes young patients coming with young hypertension or resistant hypertension, one may have to think about this entity even without classic symptoms, because only about 25% to 30% do present with classic triad of episodic palpitations and headaches. And sometimes on CT imaging, you get incidentalomas and also genetic screening of neurofibromatosis, VHL, MEN2 patients do present with the finding of pheochromocytomas as well.
So keeping that in mind, further history was taken. She did not have features suggestive of hypercalcemia. She did not have family history of hypercalcemia or thyroid malignancies and renal malignancies. She did not have family history of young onset hypertension, young cardiac events or strokes. And she did not have features of renovascular hypertension, not on any other substances or medication, and no cushingoid features as well. On examination, her BMI was 23.6, slightly overweight, and she did not have a marfanoid appearance. Her blood pressure was 160 by 90, and pulse rate was 96 but regular. She did not have features of Cushing's, and she did not have skin lesions suggestive of neurofibromatosis or mucosal neuromas, and her neurology examination was normal. Initial investigations were pretty much normal, serum potassium, sodium, and calcium. And ECG just had a sinus tachycardia with no arrhythmias, and 2D echo did not have any regional wall motion abnormalities, and the ejection fraction was normal.
What should be the next investigation in this setting?
So basically, I think this case is a very clear case. We are looking for pheochromocytoma. So the next investigational choice is the 24-hour urinary metanephrines. And actually, it is more sensitive and specific than the VMA. I think we have seen a lot of patients who are actually having symptoms of pheochromocytoma. VMA is done regularly. I think we should not do if you think about doing a urinary metanephrines. And when you look at the urinary metanephrines and the plasma metanephrines, one is not better than the other. In most of the guidelines, it says that you can select one of those. But only important thing is that plasma metanephrines are more sensitive, and urine metanephrines are more specific. So when the patient presents with a very high chance of having a pheochromocytoma, you know how to select the testing. I also want to say that you need not to do the both. We have seen certain patients, both tests have been sent. I think it is not also important. So I think most important test here, normally, is that 24-hour urinary metanephrines, and we are looking at least 3 to 4 times higher than the normal reference range when you do this testing.
Thank you, sir. How do we prepare for the 24-hour urinary metanephrine test?
So the preparation for metanephrines is not as cumbersome as ARR preparation, but there is some sort of preparation that you need to have. Few medications needs to be withheld because you can see there are a lot of interferences with methyl dopa, levodopa, MAO inhibitors and sort of medications. So about 2 weeks, you need to stop TC, tricyclic antidepressants, and antipsychotics, levodopa and methyl dopa, like medications. And paracetamol, of course, for 5 days. Again, it has some interferences. And again, we specifically say to hold 12 to 24 hours certain beverages like caffeinated beverages and vanilla containing food items and strenuous physical activity prior to the test.
Thereafter, she underwent imaging studies. Her urine metanephrine was positive. So ultrasound abdomen showed a right-sided suprarenal mass, which was 54 into 41 millimeters in size. And CECT abdomen pelvis adrenal protocol was done. There was a well-defined rounded lesion in the right-sided suprarenal region, 49 into 41 into 46 millimeters. There were no necrotic changes or calcifications. And the non-contrast CT density was 40 Hounsfield units with a absolute contrast washout of 54% and a relative washout of 33%. And there were no metastatic lesions seen. And this is the CT of this patient where there is a right-sided large adrenal mass, pre-contrast and post-contrast images.
So how do we interpret this imaging?
Yeah, you can actually clearly see that there is a right adrenal mass. I think it's a large mass. And also it is important to look at the Hounsfield units, because the plain Hounsfield units are the important point here again. Usually they are lipid poor tumors, therefore their Hounsfield units are high. If it is less than 10, it almost excludes the pheochromocytoma actually. And if the tumor is having a lot of hemorrhages, calcifications, irregular edges and all that, you also think about whether we are dealing with the adrenal cortical tumor. Sometimes they can come with aldosterone secretion, with low hypertension and hypokalemia as well. So I think interpretation, most important thing is the Hounsfield units here. Again, it's the plain Hounsfield units. Other points, of course, not that important.
So what is the role of nuclear imaging in this setting?
Yeah, when we think about, sometimes pheochromocytoma can present with the metastatic disease, the multiple metastases. Sometimes after the primary surgery, when we follow up the patients, we need to look at the metastasis if the patient has a malignant pheo. So we can do certain other testing like dotatate scan, PET-CT and also MIBG scanning, which are very, very expensive. We usually do with some, Indian experts these testing whenever it is necessary. I think it is always a multidisciplinary team approach in this kind of patient when we ask for other testing.
What are the complications of pheochromocytoma?
So again, complications of pheo is due to excess catecholamines. Not to forget, there could be occasions of pheo crisis, especially during unprepared surgeries or if you use certain medications like steroids in a patient who is having pheochromocytoma, it could lead to a crisis where the blood pressure can shoot up, end up in flash pulmonary edema, renal failure, strokes due to very high blood pressures. So apart from that, pheochromocytomas can secrete certain ectopic hormones like PTH or ACTH, because these are neuroendocrine kind of tumors, then that can lead to hypercalcemia or maybe cushingoid features. That itself would lead to other complications apart from the hypertension related complications.
So in further investigations, she did not have any co-secretion of other hormones. She had impaired fasting glucose, but her renal functions were normal.
What is the best management option for pheochromocytoma?
So I think the best management option is the surgery. I think before doing the surgery, I think the most important thing is the pre-operative optimization, because I think the most of the time we use prazosin as the blocker initially, but we should understand that prazosin is a non-selective blocker as well as it's a short-acting medication. So sometimes they can go into crisis because of the short action. And other important test is that the drug is that phenoxybenzone is a non-selective. Therefore, it actually have a long action, but phenoxybenzone can cause problems after the surgery because of the long action. They can go into persistent hypotension. So initially, you start alpha blockage during first 3 to 4 days. Then you start the beta blockers after about 3 to 4 days and try to get the target pressure up to about 130/80 and pulse rate around 70 to 80. So, and also give a high salt diet, 5 grams daily to expand the intravascular volume. That is the most important thing, unless we are going to go with problems with post-surgically. And also give the adequate fluids for last few days, as well as the final day, you have to give more fluids to expand the intravascular volume. Doing all that, like in sometimes we get the crisis even when the patient is awaiting for the surgery. We have got recently a patient who was awaiting for the surgery. We have planned very nicely the day before the surgery, because other patients are going for surgery, this patient got a crisis. So because of that, it is that important that you actually look at these patients. Pre-operative management, extremely important.
Thank you, sir. Moving on, what is the intraoperative and post-operative management of a patient with pheo?
Yeah. Again, I emphasize the importance of pre-operative management. So when a patient is going for the surgery, anesthetist should be informed to get prepared with all the medications for hypertensive as well as hypotensive crisis, and avoid certain medications like, if possible, steroids and metoclopramide like medications, because that can precipitate a crisis. And during the handling of this tumor, there can be hypertension due to excess hormonal secretion. Therefore, that moment should be managed with either magnesium sulfate, labetalol, GTN or nitroprusside. And once the tumor is really removed, these hormones are not there. Therefore, if the patient is not well hydrated, there will be a crash of blood pressure. It should be again managed with fluids. If it is not responding only, we go for vasopressin.
So she underwent laparoscopic right adrenalectomy with preoperative optimization, and intraoperatively there were spikes of high and low blood pressure during adrenal handling, which was handled by the anesthetist. And postoperatively, all antihypertensives were withheld, and currently she is off antihypertensive, clinically well, and awaiting repeat urine metanephrine assessment after 3 months of the surgery.
Yes, thank you. So that's the end of that case. We'll move on to the last session of this sector. What are the other causes of endocrine hypertension?
There are other many conditions can present with hypertension, but actually those are not that important. One that I want to emphasize is that Cushing's. But when the Cushing's can present with hypertension and hypokalemia, but at that point, actually usually this Cushing's is very evident. You know, it's a clinical diagnosis of Cushing's before you think about hypertension or diabetes or other things. Extremely unlikely that patient can present with hypertension and hypokalemia without having any evidence of Cushing's, and then you go ahead and look at this, mild secretion of cortisol. So I think that is important. Then other things like thyrotoxicosis, hyperparathyroidism, all can present with hypertension, but it's extremely rare. I think it is a MCQ kind of a answer, but not in the clinical setting.
Yeah, a few words about congenital adrenal hyperplasia. That is non-classic form where we encounter a lot of adults, but still this is very rare. And again, for MCQs as well as data questions, this is being questioned more than in clinical. But if you see people who are having hypertension and hypokalemia, if we consider CAH, it's 11 beta hydroxylase and 17 alpha hydroxylase deficiency are the main causes of that kind of a presentation, autosomal recessive in inheritance. And you need to know how to, especially the registrars, SRs need to know how to differentiate 11 beta versus 17 alpha. That's by using virilization. Because in 11 beta you have more testosterone than 17 alpha less testosterone or those products, and that's due to enzymatic deficiencies.
I think this other cause is the glucocorticoid remediable aldosteronism. Actually, it's a familial condition. Usually, they are very young patients, less than 20 years of age, coming with hypertension, sometimes having hemorrhagic strokes, also having a family history of young strokes less than 20 years. So that is one condition. If you diagnosed, surgery is not indicated, and the steroids, the patient will respond to the steroids.
Very rarely you get reninomas. Classic picture is when you do an ARR, aldosterone-renin ratios, renin is very high, aldosterone is also high. Then you think of renal artery stenosis and malignant hypertension, you can't find anything. Look at the imaging whether to see whether there's any renal tumor called reninoma which secretes excess amounts of renin. Treatment is surgical removal, and that is a very good responsive method of treatment.
Thank you. So what are the indications for screening for secondary hypertension?
So I think this is very important. All the patients, young patients with hypertension need to be investigated, less than 30, 35 years of age. Resistant hypertension, that means 3 medications with maximal effective dose. And then the patient has got adrenal tumor with the hypertension, incidental tumor with a hypertension, then you need to look for a secondary cause. And if the patient has any symptoms of a secondary cause, then I think you need to go ahead and investigate. These are the common scenarios that you get in clinical practice in day-to-day.
So in conclusion, it is important to have clinical suspicion for endocrine causes of hypertension in any patient with hypertension. And biochemical confirmation should be followed by imaging if relevant. And multidisciplinary care with input of internal medicine, endocrinology, chemical pathology, radiology, and medical genetics team is essential for the best outcome for the patient.
So thank you very much, Dr. Himansa Ranawaka, Senior Registrar in Endocrinology at National Hospital, and Dr. Udita Bulgahapiti and Dr. Sonali Gunatilaka, valuable resource persons, for that very informative session. I think now we have to distribute the letters of appreciation.
Thank you, sir. Once again, I would like to invite Dr. Dimuthu Muthukuda, consultant endocrinologist, Sri Lanka, from Sri Javadhanpur General Hospital. Dr. Udita Bulugahapitiya, consultant endocrinologist, National Hospital of Sri Lanka. Dr. Sonali Gunatilaka, consultant endocrinologist, National Hospital of Kandy. Dr. Himansa Ranawaka, senior registrar in endocrinology, National Hospital of Sri Lanka. Thank you, madam.
Let's move on to the final session, session 4. This is about a case-based approach to toxicosis. Again, one of probably the most commonest endocrine issue we encounter in clinical practice. So I would like to invite Dr. Udita Hettiarachchi, Senior Registrar in Endocrinology at National Hospital of Sri Lanka, and also our two valuable resource persons, two of the senior endocrinologists, Dr. Ranjala Migoda Vidanage, Consultant Endocrinologist at Colombo South Teaching Hospital, and Dr. Chaminda Karusinghe, Consultant Endocrinologist at the Colombo South Teaching Hospital.
So good afternoon, everybody. This is about that
case-based discussion on thyrotoxicosis. It's a common disease, but there are several types of presentation. So when you are managing these patients, there will be challenging in the management of the thyrotoxicosis. So without further ado, let's go over the cases. And there are a few cases to discuss, and there are two expert panelists who are going to discuss those cases. So first one, a 29-year-old lady at 12 weeks of period of amenorrhea with the loss of weight, loss of appetite, and nausea, and she complained of vomiting for 2 weeks duration. And she had palpitations, excessive sweating for 2 months duration. There's no previous history of thyroid problems, and there was no family history of thyroid diseases. So on ultrasound scan, there's singleton pregnancy. On examination, there's no goiter, there's no orbitopathy, and heart rate was 110 beats per minute, which was regular. Investigation showed very high free T4 level, which is more than 2 times for upper limit of normal, and TSH, it's suppressed. TRAB was not done, and ultrasound scan of neck, there was a mild, diffusely enlarged thyroid, heterogeneous echogenicity, suggestive of thyroiditis.
But what would you do now?
Yes. So this is a pregnant lady during her first trimester who presented with few features suggestive of hyperthyroidism. And biochemically, she has elevated free T4 and oversuppressed TSH, which is biochemically proven hyperthyroidism. TRAB antibody was not done. Actually, this could be due to anything that can give rise to hyperthyroidism, but we have to be very cautious before initiation of treatment because this lady is pregnant and it's her first trimester that she has presented with. Because starting treatment sometimes can cause more harm than benefit. And if we think the possible etiologies here, we have to always think about Graves' disease and the specific condition which is seen during pregnancy, which is called transient gestational hyperthyroidism. To differentiate between these two conditions, if we could do TRAB antibodies, which is quite useful in this scenario, but unfortunately she couldn't afford it and it's not available in the government sector. If we did it and if it was positive, we could have thought of Graves' disease, but because it is not available, it was not done. But ultrasound scan of the neck was done and that shows diffusely enlarged thyroid with heterogeneous echogenicity suggestive of thyroiditis. And in Graves' disease, we know that there will be increased vascularity, which was not seen by the radiologists and not really commented. Therefore, we may have to probably do the other investigations that will give us a better idea on what this condition is.
Yes. In management, I started on propranolol 20 milligram PD, and free T4 after 2 weeks, it came down to 22, which is not normalized, but it is towards the upper limit of normal. She was asymptomatic and beta blocker omitted. Then thyroid function test monitored monthly and returned to normal.
So there are a few key points here. So within just 2 weeks of initiation of treatment, you have seen that the free T4 level is also not very high. And she did not have any clinical features suggestive of Graves' orbitopathy or things suggestive of Graves' disease. And with a small dose of, actually without starting on carbimazole, just symptomatic treatment, her condition has improved. And the key points here is that unlike in Graves, we will have to differentiate between this gestational transient hyperthyroidism and Graves in this patient especially. And the presentation is quite moderate thyrotoxicosis with symptoms, which is very suggestive of the HCG effect during the first trimester. I will discuss it within the next couple of slides. And in gestational transient thyrotoxicosis, the presentation is quite mild, and this is more in favor of gestational thyrotoxicosis. Therefore, antithyroid drugs are not needed because we know antithyroid drugs have some complications during pregnancy. Propylthiouracil is used first as the first-line treatment during the first trimester, but it is associated with fulminant hepatic necrosis, and some fetal adverse outcomes. And the carbimazole is also associated with some of the fetal malformations like aplasia cutis. Because of that, we do not treat them, and treatment is actually not needed here because this is likely gestational hyperthyroidism. And ultrasound also favors thyroiditis. And TPO antibodies, if we could do, that could have become positive because this is an autoimmune condition. Therefore, if the TPO antibodies were positive, you could have thought of this as a confirmatory testing. But for this lady, we have to do long-term monitoring during pregnancy and postpartum to see whether it is really, the condition is resolving spontaneously, whether it is getting worse. So there are several etiologies for hyperthyroidism during pregnancy. There are some pregnancy unrelated conditions too, where there can be a toxic multinodular goiter, Graves' disease, subacute thyroiditis, a toxic single toxic adenoma, or TSHoma. So we have to keep these things also in our mind. That is why the patient needs long-term follow-up. And there are some pregnancy-related conditions, HCG-mediated transient hyperthyroidism, or just oversuppression of TSH and normal free T4, or just marginally elevated free T4 could be something that we commonly see during pregnancy, which is purely HCG-mediated. And this patient had gestational transient thyrotoxicosis because she was having tachycardia and few symptoms, plus her free T4 was elevated and the TSH is oversuppressed. And another condition that we commonly see is hyperemesis gravidarum, where even if they don't have any thyroid problems, but with the hyperemesis also, they can have transiently suppressed TSH. And trophoblastic hyperthyroidism, familial gestational hyperthyroidism are the other common causes that we see, not so common. Those are the other causes we see during pregnancy and related pregnancy. So you will see here the effect of HCG. HCG is secreted by the placenta, which peaks between usually 8 to 12 weeks of pregnancy. So you see that there is an elevation of HCG, which has a structural homology to the beta subunit of TSH. So it stimulates the thyroid gland similar to TSH molecule. So when the thyroid gland is stimulated, that will produce more and more free T4. And when the free T4 level is high, it will get converted to its active form free T3, and all these two molecules will have a feedback inhibition on the pituitary to suppress the TSH levels. And similarly, that can have a feedback inhibition on the hypothalamus to suppress the TRH. When the TRH and TSH is suppressed and the free T4 is elevated, that biochemically mimics hyperthyroidism. And actually the thyroid binding globulins also will be high, and that will anyway keep the total T4, total thyroxine level elevated. So we are not going to measure the total T4. Anyway, now all the laboratories measure the free T4 levels. So we can easily see that the free T4 will go high during this initial 8 to 18 weeks during that period. And thereafter the free T4, when the HCG effect wanes off, after about 20 weeks, the thyroid functions will come back to normal. So we typically see this hyperthyroid biochemical picture and the clinical presentation during the latter part of first trimester to the initial part of the second trimester.
Yes, I think this differentiating between gestational transient thyrotoxicosis and Graves' disease is very important clinically as well as from an exam point of view for the trainees. So, sir, how do we differentiate these two entities clinically and biochemically?
Yeah, actually, most of the things have been discussed. So that is the issue that we have, because we are referred these patients with suppressed TSH, maybe little bit suppression in pregnancy. So we have to decide whether we are going to treat that patient or not. So as it was mentioned again earlier, so TBG goes up by about 2-folds. As a result, the free T4, the total thyroxine level of the blood goes up by about 1.5 times. So they will have more thyroxine pooled in the blood. So as a result, the TSH goes down invariably. So even if you have TSH of 0.1, that is taken as normal, because it can go like 0.1, 0.2, or even 0.3 below the lower limit of the reference range in pregnancy because of those HCG effect of the TSH effect of the HCG. So the HCG level also determines this, because if there is a singleton pregnancy, the HCG goes up to like 100,000, but sometimes it can go up to 200,000, 300,000. So the HCG has about 1,000 of the effects of TSH. So then, as a result, the TSH can, will be suppressed, and the T4 will be slightly high. So we can leave that without treating these patients. The main thing is, when you are given a patient like that, you have to examine and see whether, and take a history and see whether patient has had thyroid problems in the past. So that is a crucial thing, because these patients also have diffuse enlarged goiter, could be little vascular, but if the patient has a sizable goiter like nodular goiter, then we know that it could be the pre-existing hyperthyroidism that is causing. And the other thing is like the effect of HCG peaks by the end of, let's say, the third month or the end of the first trimester, and then after that it should wean off. So by the 20th week, the T4 level should come down to normal. So unless the patient is severely symptomatic, then you can wait. Or sometimes you can give a small dose of beta blockers, not atenolol. You can give propranolol, the small dose, because it's not going to cause any IUGR when you are given it for a couple of weeks. So you can try that in a severely symptomatic patients. Otherwise, you can just wait and see. And talking about antibodies, in abroad, we used to do trap antibodies in patients with every patient who comes with this picture, because they can have thyrotoxicosis without goiter, and that can be Graves. So that is one of the things. And I think clinically that is how we differentiate. But if you are treating with drugs, then you can use PTU, because PTU is mostly bound to albumin and won't cross the placenta that much. But both carbimazole and PTU both process the placenta, and both are well known to give teratogenic effects. So it's not only carbimazole. Even the PTU can cause a lot of congenital malformation, and it is categorized as, I think, category D of the medicines in FDA, where you should not use in the pregnancy unless there are pressing indications. So PTU, if you use PTU, you can use it in divided doses up to the 12th week, and then see how it goes. But no carbimazole.
Right, thank you, sir. So moving to the second case, Mrs. A, 28-year-old lactating mother with a baby of 9 months old, and she complained of excessive sweating, palpitations, tremors, and she had weight loss for 3 months duration. She was diagnosed hyperthyroidism and treated with carbimazole for 2 months duration, and she was referred to endocrinologist due to poor response to antithyroid drugs. On examination, her heart rate was 110 beats per minute. She had fine tremors and warm, sweaty palms. She had diffuse goiter, but there was no bruit. And she didn't have no orbitopathy or thyroid acropathy or pretibial myxedema. Investigation showed pre-T4 2.4 initially. Then it increased up to 4.4 nanogram per deciliters, while she was on carbimazole 20 milligram 3 times per day for 2 months. TSH still suppressed, and ultrasound scan neck showed diffuse goiter, heterogeneous echogenicity with increased vascularity. Again, this patient also trap antibodies was not done because of the unavailability. And the liver function test, full blood count, and also the ESR was normal. So the further management started with PTU, the propylthiouracil 200 milligram 6 hourly, and added lithium carbonate 250 milligram 3 times per day, and leukocidine 5 drops 3 times per day, and propranolol 40 milligram 3 times per day. Patient was educated about side effects of the drugs, and the pre-T4 again. After 2 weeks of treatment with this PTU and lithium carbonate, again, the pre-T4 level is still high, 2.6 nanogram per deciliter. And again, after 2 weeks, it rises to 3.8 nanogram per deciliters.
So how do you rationalize this management?
So this is a postpartum lady in the latter half of the postpartum. I think it's after the 9 months. So generally you have what is called postpartum thyroiditis, which comes early on in the pregnancy, within in the postpartum, let's say within first 4-5 months, and that is resolving. That usually resolves spontaneously, and it's not a severe condition like this. So here it is a little severe, and the free T4 is quite high, and the patient is symptomatic. So it is in the latter part of the postpartum. So it could be something like Graves' disease, which was present and not detected, or maybe patient has had Graves during the pregnancy, and because after the postpartum, the TRAB antibody level can go up, right? The latter part of the postpartum. So, so the first, we don't know whether the patient had antibodies now. So it could be the case here. So it could be just because it's hypervascular goiter. So it could be the Graves' disease, which is giving a flare up in the later postpartum. PTU, of course, we would give PTU if you are worried about thyroid storm, right? Thyroid emergency where patient is very sick and having proximal muscle weakness, tachycardia, and sort of pyrexia, dehydration, delirium, that kind of situation. You use PTU because of its peripheral action. Otherwise, both carbimazole and PTU will act in the same way. And PTU is little more toxic because it is causing hepatotoxicity more than carbimazole. So the only indication for PTU is, if not for the thyroid storm, is the first trimester of the pregnancy. So, I mean, it would have led to that conclusion at that moment because the thyroxine level was going up. But when you treat, you have to keep in mind that thyroxine has a half-life, right? So it takes a longer period than the half-life to see any result in the blood levels. So if it is 1 week, the half-life, it will take 2 weeks to see that it is going down. So and it's mostly tissue bound. So what we measure it in the blood, but it's already in the cell. No? It's an intracellular hormone. So generally these drugs will take up to 1 month, carbimazole, to work. The half-life will be about 4-5 hours, but it will show up in 1 month. So like 2 weekly we check T4. So if it is, let's say, because it's not going down, we would have thought it is going to hit the thyroid storm and used PTU at that point. So in that way it is justified. But otherwise we would not give PTU unless it is really indicated. Because I have seen fulminant hepatitis and hepatic failure and all that with that. And lithium carbonate, again, you can use. It will inhibit the release of the thyroid hormones into the circulation. And so it is effective within short period of time. So that can be used in these patients in high dose, but you have to bear in mind that it has other effects also, like, renal effects and nephrogenic DI kind of thing. And leucoiodine, it will inhibit the uptake of the iodine into the thyroid gland. So that also can use. So the management is correct. It is fine based on the clinical picture. But if the patient is resistant, the T4 is high, but still patient is manageable, then you would increase the beta blockers and wait and see for in about 1 month and see what's happening. But otherwise, I think this is fine. Yeah.
Yes, because of that unresponsive to the carbimazole, and it started on PTU, and we increased the gradually PTU to 300 milligram 3 times per day, and again lithium carbonate is increased up to 500 milligram twice a day, prednisolone 20 milligram once a day added, and propranolol increased to 80 milligram twice a day. Leucoiodine omitted after 2 weeks, and after 2 weeks, pre-T4, T3 normal, and she underwent with surgery.
Yeah, that's, yeah.
So actually, I also agree with him, but maybe the time given to see the response is not so adequate because some people do respond a little slow. But anyway, with increment of doses, still the patient did not respond within 2 weeks. Actually, this is a real case, I think you have seen in NHSL. So we cannot actually justify a normal patient whom they are not planning to go for surgery. We cannot justify initiation of PTU 1 month after initiation of carbimazole because time duration may be too short to see the response. But now that they are planning to go for surgery, we have to normalize thyroxine level quickly in order to prevent intraoperative thyroid storm. And by giving lugolzidine, the iodine will be blocked. Plus, the vascularity also will be reduced. So we can think that probably planning early surgery, all these interventions have been initiated. So this is a case of Graves' disease actually, because the ultrasonographically there was increased vascularity and the peripherally patient was having a lot of features suggestive of Graves' disease. We could have confirmed it with TRAB antibodies. Again, the unavailability was not allowing us to do that. So Graves, like any other autoimmune condition, these diseases are commoner after during pregnancy and the postpartum period. So this lady presented with postpartum Graves' disease. And when she was not having adequately controlled with antithyroid drugs, there are several options. The radioiodine is another option for Graves' disease who are not responding to oral drugs, but she's a lactating mother, just 9 months postpartum. Therefore, radioiodine is not an option for her. And the thyroidectomy is a very good option for this lady, but we have to control the thyroxine level in order to prevent the thyroid storm. And this lady, luckily, with her treatment with PTU, lugolzidine, propranolol, lithium carbonate, her thyroid functions came back to the free T4 level, came back to acceptable levels, and she was subjected to surgery. There is one more point which I would like to highlight here. When we are doing the thyroid functions in a patient with hyperthyroidism, the TSH is oversuppressed and the free hormones, the T3, T4, will be elevated. So when we are planning a surgery or any other intervention, we should not wait for the free TSH level to normalize unless it is really not an urgent surgery. Because TSH always will drag behind and it will become normal maybe after many months after normalization, and even the free T4 levels becoming too low for the reference range. Therefore, normalizing free T4 and the free T3 is good enough if the intervention is urgent.
One little thing, this lithium carbonate, the action weans off after giving it for some times. Yeah. So I think we'll come to that. Yeah.
So the resistance may be due to many reasons, like drug malabsorption, celiac disease, and other chronic diarrheal illnesses, inflammatory bowel disease. All these conditions can give rise to drug malabsorption. And certain medications, especially some anti-epileptic medications, can cause increased rapid drug metabolism. Because of that also, the effects may take longer. And some patients, they can have anti-drug antibodies, which we don't measure. And there are few reports of anti-drug antibodies and impairment of intrathyroidal drug accumulation or action. So these are very rare instances where few case reports are seen. But common condition that we have to think is the malabsorption. And so antithyroid drugs, propylthiouracil, actually, as Chaminda mentioned at the beginning, fulminant hepatic necrosis is the most dreaded complication. Therefore, not given unless it is during the first trimester of pregnancy and if there is a severe intolerance. But mind you, this intolerance to antithyroid drugs coexist for both medications equally. Like if they have a granulocytosis for carbimazole, you cannot switch the patient to propylthiouracil. Both can give rise to the same condition. Therefore, both drugs can have basically similar adverse effects. And PTU, the action is the inhibition of the conversion of T4 to its active form T3. And if we are to suspect this fulminant hepatic necrosis, typically it occurs within the initial 3 months, like the agranulocytosis, which also commonly occurs within the first 2 months of the initiation of treatment. But this hepatic problem is not dose related. Therefore, you cannot think when the patient is in a small dose, the patient will not get this problem. And the other thing is that though they can get fulminant hepatic necrosis, which is a very rare occurrence, seen in about 0.3 to 0.6% of the people, therefore baseline liver function is not indicated. But if the patient develops any features suggestive of liver disease like nausea, abdominal pain, vomiting, jaundice, dark urine and pale stools, then the patient should be advised to immediately discontinue treatment and contact the clinician. If the patient is intelligent enough to understand, okay, get the patient to come with a liver function test. And agranulocytosis, of course, again, it's also a very rare occurrence. And if we are suspecting, we have to always advise the patient, because that is common to give rise to upper respiratory kind of infections and the laryngitis. If they develop fever, sore throat, those are the things that you have to mention, fever and sore throat. Quickly do a full blood count and see your doctor. You stop the drug, do a full blood count and see the doctor. If the patient is not intelligent enough to do that and understand that, you just tell them, if you get fever and sore throat, stop the drug and immediately come and see the doctor. And lithium carbonate actually inhibits thyroid hormone release, and the dose usually what we use is we get 250 milligram tablets. Therefore, we generally use 250 twice daily, but can go up to larger doses, like up to about 750 milligram per day. But it is in elderly people, especially who have renal impairment and the liver disease and other conditions, we have to be very cautious, because we know lithium has a narrow therapeutic index, especially when the total daily dose is exceeding 1 gram. They can get lithium toxicity, but in smaller doses that we use for the treatment of hyperthyroidism, we don't have to monitor the lithium levels. But if the patient is on a larger dose, then or any other risk factors that can increase the lithium toxicity, then we have to do the lithium levels. Or else, if the patient develop lithium toxicity clinically, like coarse tremors, nausea, vomiting, drowsiness, then we can do the serum lithium levels. As Chaminda mentioned at the beginning, there is an escape phenomenon. Initially, there will be blocking of release of thyroxine, but later on, there will be increased release. In fact, might give rise to hyperthyroidism or thyrotoxicosis with lithium. Initially, there will be blocking action, which we can utilize that adverse effect for the treatment of hyperthyroidism. Cholestyramine.
Yeah, cholestyramine, that will block the intrahepatic circulation and reabsorption of the thyroid hormone. And it's an effective thing. The cholestyramine is cumbersome to give and it is expensive with some side effects. Yeah.
Right. Let's move on to this case number 3. Ms. C, a 20-year-old university student with a history of type 1 diabetes, mellitus for 8 years duration, and then there's no family history of diabetes or other autoimmune diseases. She is on basal bolus insulin regime since the diagnosis. She had normal thyroid function test documented in her records 3 months back. She presented with unintentional weight loss, which is 3 kilograms reduction in weight within 3 months, and she denied diarrhea, steatorrhea, abdominal pain, or recent history of fever. She complained of palpitations, tremors, but there's no soreness of neck or heat intolerance. On examination, she was well developed, well nourished, there's no apparent distress, and her blood pressure was 130 by 80, blood pulse rate 112 beats per minute. And she doesn't have lid lag or proptosis. There was her thyroid gland was not enlarged, and there's no tender. There was no lymphadenopathy, but she has fine tremors. On investigation, again, the TSH is suppressed 0.003. Free T4 is more than 2 times upper limit normal, 33 picomole per liter. And her thyroid peroxidase antibodies was more than 1,000. And the serum thyroglobulin level was normal, HbA1c 6.9. And other renal function test and liver function test were normal.
Yes, Madam, what do you think about this presentation?
Yes, this is another similar presentation. The patient is clinically and biochemically hyperthyroid. You can see that the TSH level is quite oversuppressed and the free T4 is elevated. The key factor here is that the TPO antibodies are very high. TP antibodies become very high when the patient is having autoimmune background for her condition. So this is thyroiditis, which is an inflammation of the thyroid gland. If the destruction, we know there are autoantibodies which are directed against the thyroid follicular cells, which will cause destruction of the thyroid gland gradually. If this destruction is quite gradual, the patients will present to you with hypothyroidism, because with time the thyroxine production will be low and the patients will come with hypothyroidism. But if the destruction is quite rapid, then they can present with the initial toxic phase of this thyroiditis. I think this patient who presented with very high TPO antibodies, biochemically and clinically thyrotoxic, and this looks like the toxic phase of thyroiditis. So you will see here that it is triphasic. Initially there will be a thyrotoxic phase. Mind you, this is with the rapid destruction of the gland. Otherwise you see only the hypothyroidism. So thyrotoxic phase, and there will be a hypothyroid phase followed by the toxic phase, and some patients will become permanently hypothyroids and some will recover. So this is the so-called triphasic response of thyroiditis. So you will see that there are several types. This is a crowded slide, so I don't want you to go through everything. So in this patient, subacute thyroiditis or the dequervain thyroiditis, silent thyroiditis, so which is called painless thyroiditis because she did not have any pain, and postpartum thyroiditis, all these conditions are having a common clinical and biochemical presentation. Normally, it resolves within about 12 to 18 months, and some may render hypothyroid permanently. So this patient imaging is quite important. You will see that ultrasound scan of the thyroid has shown typical appearance of which you call leopard skin appearance. In Hashimoto's thyroiditis or autoimmune thyroiditis, you can see that thyroid gland has some leopard skin appearance with the heterogeneous structure. An uptake scan, if we could do, which would differentiate between the normal gland and the thyroid. In thyroiditis, the uptake is minimum, or there will be no uptake because the glandular tissues are destroyed. But in a normal, on left you see in picture A the normal uptake, and on right B you will see that there is no uptake in thyroiditis.
Yes, sir, what are the factors you would think in the active management of this patient?
Now here again the issue is patient has come with hyperthyroidism. We generally don't see these patients, right? We see patients who come with hypothyroidism are having tender enlarged thyroid, that is decavance or subacute thyroiditis with raised inflammatory markers and low TSH, and patient ill and having low grade fever, that kind of a picture. So the other this kind of a painless thyroiditis, the same thing which is painless. And there are, of course, generally we miss the toxic phase. Generally we don't see the toxic phase, but these patients, I think he has come with the toxic phase. So so that appearance is for, I don't know, we call it giraffe skin. Yeah, wolf skin or whatever. So that's the areas of fibrosis and the regenerating or the cells, there's clusters that are trying to survive. But when you get this picture in the ultrasound, they are already gone into hypothyroidism because the thyroid gland is not functioning when you see this picture. But it's, I think, reflected in the iodine scan also. So iodine scan is showing that there is no uptake virtually. And the thing is, when there is no uptake, the carbimazole we give won't work because there has to be enzymatic activity, that for us to block there. But here what happens is the destruction of the disintegration of the thyroglobulin molecule, releasing the thyroid hormones, and that of course won't respond to carbamazole, but our reaction is to give carbamazole. Even actually, I have given carbamazole even with very obvious subacute thyroiditis. We tend to give a small dose of carbamazole, but the guideline says you give only beta blockers and then control the symptoms and see. The thing is, we don't know what it is now. Here also we don't know. So it's justifiable. The 5 milligram BD is a small dose that you have given. And
6 weeks later, a patient came with fatigue, weight gain, and cold intolerance. And TSH was 11, it's increased, and the free T4 was 5.4.
Yeah, so we are in the underactive phase of that, the cause of the illness. So the patient is obviously developing hypothyroidism. So this may be contributed by our carbamazole also, but this will improve with time, or this might go into overt hypothyroidism where we need to give lifelong thyroxine.
So, in this patient with background of autoimmune disease, is there anything else that we need to consider?
Yeah, type 1 diabetes patients need annual thyroid function test, and so that is there now. So the other thing would be the adrenals. So we have to check the cortisol, and when there are symptoms, we have to do the celiac disease screening as well in type 1 patients. So, yeah.
Yes, as the time permits, we could not go for the another 2 cases, but we will stop and just go through that the last 4th case. Is it, madam?
Yes, I think this is a very interesting case. I'll just, without putting the case history, I will tell you about it. There is a similar presentation, a patient, 61-year-old female who presented with hyperthyroidism. Her free T4 was elevated and the TSH was low. Can you go to that picture where that... yeah, so, no, skip that. The picture, the slide of that struma ovary. So actually, this is a struma ovary. You may have heard of this condition where there is active thyroid tissue, ectopic thyroid tissue seen in the ovaries. So the tissues, this is, as I told you, it is usually retrospective diagnosis. You don't immediately think struma ovary because biochemically the picture nicely fit into hyperthyroidism, which is that elevated free T4 and suppressed TSH. But when there is an ovarian tumor and the patient underwent surgery and then the histology comes as presence of thyroid tissue in the histology, then you have to suspect this condition. And this could be benign struma ovary or malignant, and the presentation is basically the very same as hyperthyroidism biochemically and clinically. But mind you that thyroid gland uptake scan is also, there will be suppression because there is suppression of the gland by the presence of free T4, excess free T4, and the TSH also will be oversuppressed because the free T4 that is produced by the ovarian functional thyroid tissue will have a feedback inhibition on the TSH and the TRH, so that the patient will similarly exactly present like a hyperthyroid case, but anyway, doing the histology of the removed tumor will tell us the diagnosis that this is a extrathyroidal thyroxine secreting tissue, follicular tissues in the ovary. So this is a case like that, and again this histopathology is what we have told us that this is a extrathyroidal thyroxine producing tissues. Thank you.
Thank you very much, Dr. Udita Etiaraj, Senior Registrar, and our key resource persons, Dr. Ranjala Megodavitanage and Dr. Chaminda Garusinghe, for that informative session.
Thank you, sir. Now, to formally acknowledge the contributions of our resource persons, once again, I would like to invite Vidya Jyoti Professor Prasant Katulanda, President of Ceylon College of Physicians, to present the letters of appreciation to the resource persons. Dr. Niranjala Megodavitanage, Consultant Endocrinologist, Colombo South Teaching Hospital. Dr. Chaminda Garusinghe, Consultant Endocrinologist, Colombo South Teaching Hospital. Dr. Udita Hettiarachchi, Senior Registrar in Endocrinology, National Hospital of Sri Lanka. Dr. Neomar De Silva, Acting Consultant Endocrinologist, District General Hospital, Matale. Thank you, sir. With that, we conclude our today's session of the Ceylon College of Physicians Specialty Update in Endocrinology. We look forward to welcoming you to our future events. Until then, thank you for your valuable participation and we wish you a wonderful day ahead. Thank you.